I welcome all the panelists, and we are going to discuss about complex fractures of lower limb. We are privileged to have the President of Trauma Society of India, Dr. Sunil Kulkarni from Miraj, Dr. Amit Asgaonkar, the Secretary of Trauma Society of India. Then we have Dr. Gurinder Beri from Delhi, a good friend. Thanks, Gurinder, for joining. We have Dr. Swarendu Samanta from Kolkata. Welcome, Swarendu.
Hi.
We have Dr. Velasamy Ravindran from Coimbatore. Welcome, Velasamy.
Hi.
We have Dr. Ashutosh Bhosle from Satara.
Hi.
Hi. I thank Subbu, who is Science Integra here, who has always supported in this venture. With this, Subbu, you think we can start straight away with the program?
Yeah, you can start off, sir.
Yeah. So to begin with, let me let you know the rules of the game. Zuventus has been kind enough to support this venture, wherein we will talk about complex fractures of lower limb, starting from hip to ankle and foot. All the panelists, please keep your speaker on mute. If you want to speak something, just raise your hand so I can allow you to come in and post your question. So with this, let me take the first case, which is by Sunil Kulkarni. So this is a fracture, a young guy, high velocity trauma, obviously, extending from a proximal tibia going down to shaft, which is comminuted. Sunil, do you want to tell every one of us here how bad was the swelling when this patient presented, and what did you do initially? Unmute, please. Unmute. Now speak. Yeah.
I am not muted.
Yeah, you can speak now.
Okay. The swelling was tremendous. Was having a lot of pain. We were thinking of whether it is a compartment syndrome, but not much of to look. There is no compartment syndrome. So I usually, whenever there is intra-articular extension, my always plan is any periarticular fracture is a span, scan, and plan. So I put on immediately on external fixator. I always wait for 8 to 10 days, let the wrinkle sign come positive, and then we plan for further.
Okay. Ashutosh, question to you.
Yes, sir.
If fracture blister appear in 24 to 48 hours in this kind of a patient, how will you deal with those fracture blisters?
I usually keep on dressing them. The question is whether those are hemorrhagic blisters or simple blisters.
Yeah.
Hemorrhagic blisters will indicate that that is a more soft tissue damage is there. But still, initially I used to puncture them, but nowadays I preserve them, keep on dressing with the external fixator, let them settle down on its own.
Okay. Swarendu, what will you do with this?
Puncture any of the blister. Hello, can you hear me?
Yeah, you can. We can hear you. Tell me.
I will never puncture any blister, whether it is clear or hemorrhagic.
Okay.
Only thing is that I completely agree with Ashutosh. If it is red one, the internal declubbing is much. I will only dress and I will put the X-fix on.
Okay. Amit, what will you do?
Nothing with the external fixator. I generally don't put the external fixator. I put it in a slab. Though external fixator is also mandatory, but if it is an external fixator, in this case, it should be a joint spanning fixator.
Amit, let me stop you there. See,
Yeah.
we are not talking of only proximal tibia. This is a very, very unstable scenario.
I understand. I know I'm talking about this fracture only.
So still you will not put a
I would-
fixator in this fracture?
Yes, definitely I would put, but again, even in a slab, I think it should be okay. Slab elevation and wait for a few days, everything would settle down, and then do the definitive fixation. Oh, here, where will you put the pins in this fracture?
No, we can put far away. We can put in the lower
Even
end of
if you
femur
put
there.
it in the distal tibia and the distal femur, the proximal tibia, you are not going to put the pins, of course. I don't
That's okay.
think so.
But at least if you create a biplanar construct or a tripod, you can still
Yeah, that's
get
true.
some stability.
You are right for the stability, but then I am really very worried about the pin tract
Yes,
infection.
whatever you wanted to say something.
Yes. Thing is that I will always put internal fixator. This sort of fracture with big segment in upper half of the tibia. It is very difficult with slab. Even I will sometimes with the slab.
Okay. All right.
Getting
Gurinder, you want to say something?
I think the problem with this is going to be putting any sort of a fixator is a problem. Because whatever you do, this portion is going to be almost hanging loose, and you won't get any stability. The only fixator that I would definitely put a fixator. The fixator, I would actually put a articular screw here, hold the joint, then put one ring Ipsilateral there, one ring Ipsilateral there, and hold it in track. I don't think going across any gives me any stability on this. This is loose.
Okay. Sunil,
we are getting a lot of it.
What, Sunil?
Technical team.
A lot of ego is there. Babulkar, can you manage the
Yeah, there's a lot of ego.
Lot of ego.
Lot of egos.
Orthopedics have a lot of ego. Yeah.
Somebody is using two earphones. On the computer is on and in the earphone
Guys, just check. Somebody might be having two earphones. That's what Samantha said.
Yeah, computer is on and the earphone is also on.
from the technical team side, if you can keep two computers away, it will be better. Okay, Velasamy.
Now it is okay. Now Babulkar, you go ahead.
Velasamy, tell me, what do you want to say?
See, I have treated in both ways. One putting on a plaster, the other one putting on an external fixator. The meaning is, if it's going to be a hemorrhagic blister, which is going to be a high intensity trauma, you're going to leave it for a longer time, so which needs an external fixator. But if it's going to be just a serous fluid blisters here and there, few bits and pieces, I would rather just put a plaster for a few days and then go for the definitive fixation. So both ways I've done.
Okay. All right, point well taken. Sudhir, go ahead.
See, it is nothing to do with blister. It is the injury to the soft tissues around the muscles, everything, and the swelling. If you do it earlier, there is a high chance of the skin may not heal. You may need to have a plastic surgical procedure or something. So external fixator and plasters are so cumbersome, and you can't see every day. If you put a plaster, you have to remove every day. You have to see it. Dressing is a problem. The movement is a big problem. And elevating, keeping it is extremely, and plaster will not give any stability. That fracture needs a little bit stability to reduce the swelling. That's why nobody in the world now doing any plastering. Those who are, I don't know why it is changing from plaster is gone. For any periarticular fracture or such a shattered fracture, the plaster should not be considered as a primary line of treatment.
Okay, Sunil, let me stop you there. If there is a undisplaced, minimally comminuted proximal tibia, what can probably accept posterior slab with a anterior window, and we can still inspect the fracture blisters and the swelling and the appearance of wrinkle over the period of time. But it has happened to me personally also that I kept on looking at the anterior side, lateral side and medial side, and patient developed posterior blisters.
Correct.
So there is no way in a posterior back slab with a ability to see, and physically to take the limb out every day to see posterior blisters becomes very cumbersome for the patient. You are inflicting trauma. We are not allowing that soft tissue to heal and the swelling to go down.
One more
Anyways, let's go ahead on this.
One more advantage of external fixator is once you stabilize this, see the alignment, see the previous X-ray and this X-ray. You can literally distract it and align it and take a CT scan after some sort of reduction. See the difference. You can match the difference, especially lateral. You can see how much that fixator has aligned this fracture. So it is.
So Sunil, my question to you is now, is that a routine for you recently that you always put a fixator and then take a CT scan, or CT scan, fixator and repeat CT scan?
I always do a span scan plan. Always do any Schatzker 4, 5, 6, not 1, 2, 3. 1, 2, 3 don't require. But 4, 5, 6, always external fixator.
Okay, Amit, do you want to say something?
Even after I have seen.
Sunil.
All right,
Sunil.
Amit.
In this case, Sunil, how will your CT scan help? In this case.
No, that we will show. We will talk about that. We'll talk about that.
No. But in this case, also, is Sunil going to do a CT scan?
Yes, he has done it. We'll talk about it. Yeah.
No, but that only. The message should go, even if it is not a periarticular fracture, even if it is not an intraarticular fracture, you are doing a
This is
CT.
intraarticular. This is intraarticular. It has fallen into place because of the difference.
But you don't expect depression. You don't have a flaying. You don't have a separation of the fragments. You know where the intraarticular element is.
See it.
What was not seen on the X-ray, you see it now.
And that's why, Amit, even your expert eyes felt it is important to do a CT scan.
CT scan is mandatory. CT scan is mandatory. CT scan fracture. If you see the primary X-ray before the X-ray, it was extending towards there. So it has to be CT scan.
The thing is that everyone who's watching this, everyone and every orthopedic surgeon who's watching this, you have to give them a message. In such cases, you have to do a CT scan.
Yes.
Everywhere, everyone. That is what we see here. We on the webinars, we are giving lectures, we speak over it. But in practicality, does everyone does it?
Academically speaking, you should do it.
Academically is fine.
You should ask the patient to do it. If the patient doesn't do it, that's another issue. Okay, Swadendo, you want to say something?
No, I was pressing on the CT scan is mandatory for any intraarticular fracture, proximal tibia. This message should go to all the viewers.
Absolutely. Ravindran?
Yes, I agree. What
Rinder?
Sunil said initially. That's
Okay,
true.
I mean, I totally agree. A CT scan, I would definitely ask for it. Whether the patient gets it or not is another story.
That's another story. Correct. I absolutely agree. So, Sunil, Ashutosh, sorry, I missed you on
Yes.
that. What will you do?
Same.
Same. Okay.
Span it, then get a CT scan, then and then plan.
Okay. Sunil, I want to get back to you on this. Now, you have submitted the slides which shows only 3D CT reconstruction to me, which is brilliant. Will you, in an intra-articular fracture, also not look at tomograms? Because that will give you the amount of depression.
I have the tomograms of these patients also, because we need to see the articular depression is not seen properly in this 3D reconstruct, but 2D reconstruct will show you. I'm sorry I did not send you this.
So send that one slide, because this case is selected. This case is selected for AO armamentarium.
Okay, so I will
So
send.
I want to add.
Today. Yeah, I will send it. Yeah.
Okay. Gurinder, what is your favorite? 3D CT reconstruction, CT tomograms? What would you order your radiologist to do?
So actually, the 3D is good because it's easy to explain it to the patient. But in my opinion, I actually prefer the tomogram cuts, whether it's sagittal, coronal, or axial. I actually get much more information from them compared to this. But this is sort of easy for the patient to understand. It's not what I'm looking for. If given an option, I can do without it.
Okay. Question to you, Swadendo, before you ask me, is if there is a suspicion of intra-articular injury, which is either a ACL or PCL, not in this case, but if there is a suspicion, will you also do MRI? Will you also consider doing an intra-articular reconstruction? You are a very prominent figure in Indian Arthroscopy Society now. So what's your feeling about this?
The classic teaching and the how you see the proximal tibia fracture or the intra-articular fractures is around the knee, around 50 to 70% there is intra-articular injury. Never focus on the intra-articular injury like the ACL. PCL goes rarely, you can see the shank. Primarily for fracture fixation. The basic teaching is that after fixation, please check the mediolateral and the anteroposterior stability. If you are seeing after fixation that the mediolateral on the epilaxity is there, please note that and fix it for some time with the X-Fix 7 for healing of the soft tissue. Never reconstruct the ACL or the go for the PCL unless if it is a bone chunk, that is a different story. It cannot be done during the fracture scenario.
Okay. What's your thought on this, Ravindran?
Yes, I mean, mostly the ACL will be intact with this sort of a chunk anyway. But I would get the MRI scan or the clinical examination once the fixation is done. I will not embark onto that very urgently with an MRI now.
Let me stop you there. Once you fix, everything is fixed, fantastic. This is the patient, this eccentricity we are talking of, and there is some anteroposterior laxity. Will you do a ACL reconstruction? I'm talking of associated ACL PCL injury demonstrated on table post-operatively. What will you do?
Now, if the collaterals are intact, obviously the collaterals will be
I'm
intact.
talking
The
of ACL and PCL.
body constructor. So the ACL and the PCL, I'm going to delay it. So
Okay. Amit,
I'll delay it
Amit,
by
what
a
will
few
you do?
months. Yeah, I'll delay it by a few months.
Unmute yourself.
Unmute. I thought it was unmuted. Yeah.
No, Amit.
Yeah. In most of these fractures, generally it is an avulsion injury. Most of these avulsion injuries, after fixation of the fracture, the bony part gets gummy and it gets stuck to the bones. It's not from the many a times it is not a mid substance tear of the ACL. So I would not fix it immediately on table. I would delay the fixation.
That's what I wanted to bring out. MCL and LCL will behave differently in these proximal tibia fractures, which of course need to be addressed to post-operatively. But if it is ACL and PCL, you can sit on it for some time till the time patient doesn't become symptomatic because of ACL and PCL 6 months down the line. Sunil, do you want to go further on this, please? So what was the plan, Sunil? Explain us on this case.
Plan is to have reconstruction. Again, I am getting echo.
Yeah.
You come nearer.
Nearer to what?
Speaker.
अरे वहाँ पर तो
बोल
speak.
Yeah.
Only one.
It is coming back.
Yeah. Come to the microphone.
Sunil, I think the rest of the people can hear well. I think it's your end, which is
No. I am not done anything.
Okay. So true. In the meantime, when we can fix this.
This is what Sunil planned. He went ahead with intra-articular fixation. And two plates were used. A longer lateral plate and a shorter different length radial plate. So bicolumnar fixation with intra-articular fixation.
So, what is the timeline between the injury and the operation?
I think when did you operate? 10 days. That's after 3 months. And that's after 1 year, right, Sunil?
1 year, 2 year, 3 year, 4 year. 4-year follow-up.
And that's his range of motion.
Just a small point I want to raise there.
Good.
Yeah.
A small point I want to raise there.
Yeah.
The lag screw is from medial to lateral.
Lag.
If you look at the fracture initially, it is a lateral.
No.
It's a lateral condyle which is
That's
extending.
what I wanted to stress that, Amit. You see the scan. It is a Schatzker 4.
It's a Schatzker 4. It's a Schatzker 4.
From crossing the lateral. See this, it has crossed the lateral condyle. That means it is the energy has dissipated where the shaft has taken the brunt, and that is the reason it has got undisplaced for Schatzker 4. Otherwise,
Understood, but he is talking about the placement of the lag screw.
I am talking only about the lag screw.
correct. So it should have been from lateral to medial.
Lateral to medial. You have put medial to lateral.
That's okay.
No. Sunil,
Soft tissue may be a problem.
Sunil,
Yeah.
what you have done from medial to lateral is the ideal way of doing it.
Yeah.
You have done correct. You have done correct.
See, Schatzker type 4, which is the medial condylar fracture, is a big troublesome fracture. So that fracture has to be dealt with a medial-lateral screw with a buttress plate which is placed like this.
Correct.
This is the right thing to do.
Correct. It is the right thing to do. It is never from the lateral to medial.
If you
It's from
do
medial
lateral to medial, it will be a birbal ki khichdi trying to hold from a distance. You can't do that. So it has to be a medial to lateral screw, the same principle as we attack posterior malleolus or the same.
Lag effect has already achieved, so we can fix it.
Correct. So
I mean, the only thing is, I think the lateral condyle looks a bit smaller. The lateral articular surface looks smaller than the medial. So the basic orthopedic teaching is go from the small to the large, because then you're very sure that you fixed it. That might be the only argument somebody might have against it. When you see the fracture line is actually much towards the lateral side. That's the only reason. But it's okay. I don't think
Correct.
Yeah, that's the only reason. Yeah.
Lateral side with the plate. What was the first step? Did you put the lateral plate first, Sunil?
Always medial side.
Always.
Always.
You put the medial plate first.
Always medial side, because that is the thing we have to prevent the varus, which is going to collapse. Don't put a lateral side on. The lateral side is just.
No, because your fragment, the lateral intra-articular fragment is an oblique fragment which is going down, so it will need the buttressing. So you put a medial side plate first, and then you buttress it from the lateral side.
Always medial side first. Always.
Whenever you plan for a sandwich plate, the message to the delegates is that always start from the medial, lateral is always the second one.
Yeah, correct.
the point also I wanted to make here is these two plates has to be of different lengths.
100%.
And only thing I wanted to ask is whether this is a absolute stability or a relative stability, Gurinder.
so. This would have to be a relative stability. You will never get an absolute stability into this. So you need to allow that micro motion to happen in between the fragments. You try to add any more screws than you've done, then this is going to be I mean, even one screw in between would have actually spoiled it, and you would not have got a union at all. So this is brilliantly. The screw placement is absolutely brilliant out there. Absolutely as recommended.
No screw in a fracture zone.
That's right.
So Shrut,
Yeah.
I want a comment, or just go back one slide. I want a comment from you only.
Yeah.
That the longer plate which is on the lateral side, do you advocate to put the locking screw at the end of the plate, yes or no?
No.
Yes. So that is the message to the delegates, that whenever you put the longer plate either of the side, never put the end screw at the locking mode.
Yeah. Or put an oblique screw.
Oblique screw, yeah.
Because see, there
Sunil, can you show the full length of the tibia fibula? Full length. Okay. Very nice. Very good
Very
union.
nice. This is brilliant, actually. This is very good.
So this is one case which has gone from India to be in the AO museum. So similar patient which I received, 38-year-old guy. This was a fracture. Similar kind of a situation. Again, an intra-articular fracture, Amit, with
Yeah, this is more of a proximal fracture. Though it's extending down, definitely, but more of a proximal.
Similar fracture.
Here you have a posterior proximal element also.
So what I usually do is, of course, I put them in a posterior slab and repeat the X-ray with some amount of traction. I don't apply X-fix and then do CT scan. I do CT scan and then I put external fixator. So this was the CT which was done. Huge amount of comminution. Again was requiring and begging for more than one plate. So that's the amount of intra-articular extension.
What is the logic behind that, Sushrut?
Logic.
Going reverse back, don't do a scanning and then.
No. I agree with you that you should do X-fix and then do scan. I agree with you. I don't do it. So that's what I did. So longer plate laterally, because the more
posterior plating, proximal.
No, wait. I'll show you. Not required. I'll show you why it was not required.
CT.
Sorry.
Just go back to the 2D CT images.
Yeah.
The tomogram 2Ds.
I don't have it, but if you see on this CT on the right side, this thing,
The posterior medial fragment, no?
the entire fragment of medial condyle is one fragment. See that fragment and see on the left side. That entire fragment is coming as a medial condyle fragment coming all the way to laterally.
So this is the spike is actually medial rather than being posterior.
Yes, correct.
Were you able to manage to buttress the apex of the fracture?
Let me show you the result. The way I tackled this. So lateral compression after articular reconstruction, lateromedial screw, articular reconstruction, lateral buttress, and medial buttress. Buried lengths, X-fix, I continue. This X-fix which I have applied for taking the skin down, the swelling down, is continued even after the final fixation of plate is done.
Why?
Because the swelling is still there to some extent, number one. Number two, I think there was some lateral laxity, I thought, on table. So I just decided to continue X-fix.
So that's a transarticular X-fix, is it?
Yes, that's a transarticular X-fix.
With your lateral fragment.
See the lateral view.
Yeah, the lateral AP view, the lateral tibial fragment is out. Basically, the femoral condyle and the tibial lateral condyle should come in the same line.
I agree with you. So there is some widening of
widening of the condyles.
Yes.
Meniscal entrapment.
Maybe this
There is some depression on the lateral tibial condyle.
Totally
But
agree.
anyway, most of the tibial condyles do well, definitely.
So this is as it went.
That's very well done. Yeah.
How big was the depression on the lateral tibial condyle?
So I did a submeniscal approach. I lifted the lateral meniscus up, and from the medial side through the fracture, I lifted everything up. On table, I thought that it was brought to almost normal, but obviously there are some views, not a dead AP, some rotation which will demonstrate you this. But I hope sincerely that that lateral femoral condyle will not sink into that hole which was there. And so I went on. I was still skeptical about the broadening of the proximal tibial plateau. There were some comminuted fragments which were stuck there, and it was not allowing me to compress the proximal tibia any further. And it went on to healing, and that's how it is. So, Swarnendu, your point, see my last screw.
Yes, that is the recommendation now. And this is for all the who have joined here, that whenever you put the long plate either on the medial or lateral, don't give the locking screw at the end of it, and try to give the cortical screw that to in 15-20 degree of obliquity. So that lessens your stress at the end of the plate.
So, do you think this required another plate posteromedially?
I don't think so. Now it has healed. So let me.
It has healed in a good position, no doubt about it.
Let me take you back to this city. See the posterior side. Of course, if this would have been a separate posteromedial fragment, you would need it. Now let's look at anterior side. The entire medial condyle extending from
one
posterior
piece.
to anterior is one unit.
Okay.
So can I make a small comment on this?
Sure.
One thing is that whenever we are discussing about the medial condylar fragments,
Yes.
there are three sort of apices.
Yes.
One is that is anterior, one is absolutely that is dead medial, and third is at the posterior side.
Correct.
This falls into the category of the second type. This is if you reduce it, it will fall into the medial second type. So the only the medial plate will help you.
Correct. Correct.
It's no need of posterior plating.
No need of posterior plating. Correct.
So, sir,
Yeah. Yes,
if
Ravi.
the fracture is not reduced on the table,
Uh-huh.
would have thought about a posterior plate or posteromedial plate?
No.
Just because it's reduced, you left it like that.
No,
Would I
no,
agree?
no, I always aimed for what I'm doing and what I'm planning to give as an output, because the entire medial condyle was one piece, Ravindran. There is no way it will not reduce. The thing which always should bother you and me is this widening of tibial plateau. Because
Yeah.
huge comminution there.
Yeah.
So even though I did a submeniscal approach, there is so much of a comminution which goes in this area. It's physically impossible to lift all these tiny fragments.
Yeah.
They will interlock within each other and they will give rise to some broadening which you cannot correct.
Completely agree with Sushrut. This sort of fracture never classified under this fracture classification. Basically, these fractures are classified by the fracture dislocation classification. So this is a fracture dislocation.
Can I
Just
ask
out of academic interest, how big is the depression on the lateral tibial condyle?
It was very craters which were created from 3 to 6 centimeters. So I had to add 3 or 4 craters, which I addressed because I was to do medial plating anyway. So I gave a nick and transfracture those craters on the lateral side. Sunil.
So, this depression after elevating, did you need definitely we do that? Did you need to put any strut grafts over there to keep the elevation there? The raft plate is doing its job definitely, but then raft plate, the distance between the two screws also quite long enough so that the minor small fragments they can go again into depression like which has happened over here.
So 3 years back or 4 years back, I was a very enthusiastic bone grafter, pushing hold it and pass raft screws through the graft. But now I am convinced that create an intricate of raft screws parallel to each other, like we have done here. Bone grafting is not required. Adding more.
No, Sushrut, what happens if they are big fragments, then the raft screws can hold. But if they are very small combinations, then even between the raft screws, they can go into depression again.
Yeah, I agree.
Sushrut, there is a controversy now about the raft screws. So what Josh is saying is we're putting them maybe too close to the subchondral area. So we need to actually go slightly below. Otherwise, they actually never get healed, never get nutrition or something. So they normally will necrose. According to him, I go pretty high, but I think I've been trying to see if I can get it low.
Yeah, even here I did go very high actually.
These are all 3.5 fully threaded.
Yep.
Yeah. What are those two extra screws you put from there, lateral to medial?
From lateral to medial. Hold them out of the once I lifted to hold, we are just trying to support them properly. The lifted articles surface. Sunil, you are something. Your opinion on graft?
Graft, I don't. I even published it that it is not necessary. For calcaneus and proximal lateral condyle tibia, we don't require a graft. Raft plate will take over everything. There is no need to put the graft.
Okay, let's move on then.
Yeah.
So that's how it is. Well held down, well aligned with good posterior slope. Happy, Amit?
Yeah, good, very good.
Okay, so take home message which Sunil has created. You have to understand the fracture pattern, respect the soft tissue, care for planning, appropriate implants by condylar support to avoid varus, good alignment with rotational stability. So, what in your case, man? You want to take this?
Yeah, we can take this.
Yeah, tell us.
It was another X-ray just before the fixation was there, but I think we are missing that. But this is a subtroch fracture. Anybody in the faculty in the subtroch fracture, do you think that this implant is okay or this should be abandoned?
Amit.
If it is a subtroch, this is absolutely contraindicated at 135 degrees.
Yes, this
You
is
have to have a 95 degrees, whatever, even if you do a DCS or a condylar blade plate.
so this is
Today I
totally,
would prefer a
this is-
condylar blade plate. Yeah,
this is totally contraindicated for the subtroch fracture.
yeah.
Next one. So this was coming to happen. So this was after 10 weeks.
10 weeks. Gurinder, what do you want to do, man?
It was day one failure.
Day one failure, yeah.
Yes.
Yeah.
Because probably the plate was tightly maneuvered towards the and aligned to the forcibly aligned to the shaft. That was the reason this is happening, and plus the reduction is not there in the lateral view. And
What
the
10
wrong
weeks?
choice of implant.
Sunil, अभी क्या what is your plan now?
Who, mine?
हाँ, तेरा plan. What's your plan?
Oh, we had discussed before previous webinar.
So this was there. So just go ahead.
You want me to again do it? If I don't agree with the other faculty, I'll tell you. I take it as a 10 weeks means it's a non-union. And any non-union requires stability.
Next one.
Gurinder,
Yes. So for me, I think all the subtroch non-unions essentially will need to go into an absolute stability mode. And for me, I mean, I've actually taken to plating all my non-unions of the subtroch. So, and my favorite implant for this then becomes the Smith & Nephew proximal femoral plate to realign them, graft them, or whatever is required in those kind of scenario. This is very, very fresh. So I don't think at 8 weeks I would graft it. I think I would go with the idea of getting a compression across the fracture, putting a plate, and seeing if it needs to be made absolute stable. Even if it requires another plate anteriorly, I would happily put another 3.5 plate anteriorly at the same time.
Who agrees on the lateral? Who is there for the lateral plate?
So I'm going to start with the lateral plate, boss.
I would do a plate with a nail with a plate.
I personally would have gone just with the plate, in my opinion.
Anybody with only on the lateral plate?
Yes, Fernando?
Yes. Anybody with only lateral plate? What Gurbinder is telling?
no, I think
No.
Okay. Go ahead.
in a failed situation, there has to be lateral plate plus anterior plate if at all we want to consider plating.
Yeah. Two plates or nail with plate.
Ashutosh?
Yes, sir.
Probably needs a combination, nailing and plate.
Ashutosh suggest
I will go with the plates only, 2 plates.
2 plates.
Lateral and
Actually,
Which plate would you use? Which plate, Ashutosh? If at all you're using a plate?
95 degree DHS.
A
And
DCS.
DCS, sorry. DCS and anterior side DCP.
A normal plate.
Yes, normal plate.
Okay.
And I will not bone graft it.
Would you put a
5
bone
weeks
graft?
only. No.
nobody with a nail. Nobody with a nail.
Yes, a nail with a plate, Swarnendu.
Nail with the plate.
Nail with a plate. We both are for a nail with a plate. If at all you have a lot of void, which I don't think there's a void, grafting. And a grafting, if it is required on the medial side, not just a powdered graft or just a cancellous graft, a fibula also I would use, if at all needed.
Fibula.
Intramedullary, yeah.
Why a 10 weeks fibula?
If at all needed, on the medial side, subtrochanteric.
Okay.
Yeah, it would be an overkill, definitely, but then I would judge the situation and I would be prepared.
Who is operating?
I'm operating.
Fracture table.
Lateral table, I'm doing it. Subtrochanterics.
Who is doing fracture? Also,
I do it in the lateral position.
So the
There's a lot of
Sushrit, the audio is troubling.
Yeah. Tell me, Gurinder, say.
So okay. So now I think
Fracture table.
I'm actually going to go do these in the lateral position. I've shifted very recently, but since a year I've shifted, and I think much happier now in the lateral position. Allows me much more laxity, putting plates and all, adding any adjuvant fixation much easier in a lateral position.
Ravindran?
Yeah.
My thing is I always do a fracture table. Only if the obese patient, then I'll do a lateral position. And if I'm thinking that I'm going to augment with a plate and a circulage wire, if my pre-plan is like that, then I look for a lateral position.
Sunil, position of the patient, an option. Sunil?
Sunil is not audible.
If it is a subtrope, Sushrut, since Sunil is not there,
You are muting me.
Okay.
Can I speak?
Mullah nice. Okay, speak.
How can you can be muted?
He has already muted me.
No, we can hear you now. Tell us.
I always use a fracture table. I never done for last 30 years. Never done anything in lateral position. Always in supine position.
So, Sruth, can we take a vote on who is on lateral?
It's an individual choice, I think.
It's an individual choice.
Yeah, and it's an individual comfort zone.
Yeah.
Whatever your position. I think
Exactly.
I'm more comfortable with the lateral position.
Exactly.
So this was X-ray with immediate X-ray and 6 weeks and 6 months follow-up with a long PFN.
Okay.
It's over.
Huh?
That case is over. It are united.
Yeah. It go back. It is united. Yeah.
What's the name? You were all for the dual fixation. You done single fixation.
No. That's why
It is really united.
That's why that every time it is not like so rigid. So it was only 10 weeks. Only 10 weeks. It was not very long non-union.
It was not a long last.
It would have been like 4 or 5 months. I would have done a different. Even I would have added a anti-rotation plate. As because it is just 10 weeks, I have already done proper reaming, long PFN.
Right. Good. Yeah. So this was a 25-year-old young man, road traffic accident, all closed injuries. This was this is the only injury. Only the femur was injured over here, and an acute injury. Immediately he came to me. The knee X-ray is the next. Sushruth, if you can go to the next slide. Yeah, this is the knee, the same side knee. This is the medial condyle, and go back, Sushruth. Go back. Yeah, and this is. I think you have seen a few. Sushruth, Sunil, you must have seen this. Any opinions? Yeah. Swarnendu, what will you do?
So basically, we are discussing about the segmental femoral injuries. This is not the
segmental means it is three-part femur.
This is a basically 4-part femur.
Yeah, 4-part femur. Yeah.
This is 3-part. This is a 4-part femur. So this is the neck. There is a the basic cervical sort of injury. Then the shaft is comminuted and the intra-articular injury. So you have to go with it. You have to reconstruct the medial condyle of the femur. Then go with a long your plate on the lateral side and fix with a small 2-hole
femur plating you're talking about.
Femur plating, small.
So you open the fracture to do a femur plating?
Just 1 minute. While this medial condyle, fix it. Go with a long.
Medial with what?
You can fix with a screw and 3.5 recon just to neutralize that.
Okay.
Then go with a long lateral femoral plate on the lateral side from this femoral shaft fracture.
Minimally invasive or opening?
No. You have to open. You will try close, but you will fail because this is completely rotated like more than 90 degree. So this is
not a bridge plate.
More than 3/4 of this fragment is gone. Very minimally, so that you can just derotate the fragment. And upstairs you can give with a 2-hole DHS so that there is a lot of space in between the 2 segments, or else you have to overlap the implant.
Yeah.
You cannot leave any stress area in between the 2 implants.
Yeah. How will you overlap the DHS and the lateral plate?
So that is the problem. That's why I'm telling, because if you are planning for this thing DHS on the top, then you have to use only 2-hole DHS with derotational screw.
Yeah. Ravindra?
I'll go for sure. Amit, that Gujarat Fellows nail, which have the bolt distally, that is the retrograde nail, with 3 or 4 bolts, 5 bolts distally. That can hold the medial condyle with the nail, with the retrograde nail. And of course, the proximally I'll do overlapping with the DHS on. So it's a double implant, retrograde nail with the DHS shot.
So the reduction, the distal reduction, this medial condyle reduction, how will you get
medial condyle? I think you'll be able to reduce it by a closed method. If it doesn't,
the slide is gone. So now this was done. I opened the fracture. The fracture was opened from down. I did an anterior TKR incision, reduced the medial condyle, and then put this guide wire, and this retrograde nail was put. This is the retrograde. You all know I do it regularly. This has got around 4 screws distally. This has 2 obliques and 2 lateromedials, and that one particular is a bolt, a condylar screw which can be tightened from both the sides. That thing you can see over there. And after doing this, I just relaxed. I came out, and this was in the supine position. Patient shifted to the fracture table, and all these were through the condyle. And this was AP locking in the retrograde nail, which was seen. After doing that, I put the DHS proximally, and one of the DHS screws is through the lateromedial locking of the retrograde nail also. So both the sides I could get biplanar lockings.
Amit, how did you manage to target that screw through the nail? Was it luck or a trick to do that?
No, it's actually not very difficult. Later on, retrospectively, I thought from the lateral side, I adjusted the leg as well as the C-arm, and I could get the hole first through which I could pass a lateromedial locking into the nail, and that plate was adjusted to the hole. Look, that is the reason the plate is slightly off in the lateral view, you can see. And once I adjusted the plate, I could pass it through the plate hole as well as the nail holes. And this was the immediate post-op X-ray. And
you want to say something on this, Ashutosh?
Yes. These medial condyle fractures are usually a shear plate. So I would keep a buttress plate on the medial side. In addition, if I am not having good purchase on that condyle through the nail.
Okay.
Correct. Absolutely right.
Yes.
I had kept the
that fragment little bit is tilted.
Can you show the long femoral X-ray?
Long femoral X-ray.
Next one. The post-op, long post-op. This one. The Amit, I know that because we have discussed this before. That's why I have given a different option, because we have discussed this X-ray with
new case and discuss.
The thing is that if you see the middle fragment, I will take the opinion of the faculty who are going to just derotate the fragment. Yes or no?
So I didn't do it on table there.
Derotate.
I thought I would do it as a secondary procedure.
Oh, the middle.
So, I mean, can I differ with you, Amit, on this plan? Sushrit, is it okay to talk?
Yeah, sure, Gurinder, please.
Okay. So, I totally agree with Dr. Samantha that the middle fragment was likely to go into non-union, and I totally take your point, Amit, that you can come back later and do it because it's a fairly extensive surgery. Can I just differ and go with the idea that I would have fixed a medial condyle first and put a small T buttress plate on there, just as you said. So that's a fairly major fragment for me. Put that, start with the lateral plate from the side, like a list kind of a plate, extend it as far as it will go, and then try to get hold some sort of and push this fragment underneath the plate at the same time. Then I would actually go with I would done a pre-op measurement and check what is the length of the proximal fragment which is there. And I'm actually quite happy with the idea of, once I do these two things, go and put a PFN, a short PFN, and actually get my stability. So I would have an intramedullary, and I can adjust the screws of my list plate, front and behind the nail if it comes to that. It's just a thought. I'm sure you got a very good result, and it looks very, very good for a very difficult.
Surinder, you are absolutely right. I got a lot of suggestions that I could have done a single implant, that is a PFN nail. My only problem in the PFN nail, I feel, is distally in all these unstable shaft fractures, distally we only have lateromedial lockings. I am really worried. Now, some implant manufacturer, I feel, has to come out with a PFN nail, a long nail which has got an anteroposterior locking also in the distal fragment for these type of fractures. So you get good biplanar stability and biplanar fixation and locking distal fragment. Now this fragment, can you just go ahead in this case?
Can I come in, Sujit, now?
Yes, Sunil, please come.
Yeah, because this is still in Varas. I know the case. I have seen this result, but this is for newcomers. This is in Varas because there is a gap. There is a classical wedge effect has been occurred. So I would have reduced that and put a PFNA blade, and as Ashutosh said, put a small buttress plate on the medial side with the 2 lag screws. The nail I would have kept little shorter, not below that, because distal fragment is back. And what I'm getting a posterior screw implant. So with 3 bolts, 1 buttress plate on the medial side, and the PFNA blade, which will give you excellent stability on this fracture. Usually it is ipsilateral neck femur and shaft femur, but fortunately this patient has got an intertrochanteric fracture, which is a cancellous, which can get in the one implant with the PFNA blade, get on a static operation. I also put 1 derotation screw to prevent another.
Probably, yeah, you are right, Sunil. A derotation screw added over here would have been a better option, because now the intertrochanteric element is only on the DHS screw. Correct. And you feel this is Varas.
There is a tilt.
Rotation.
The tilt is not reduced. Either it is compressed or damaged.
It's a rotated fragment.
This is
maybe rotated like this.
Right. The middle fragment was totally free flying. That's why it has been fixed in rotation.
And
now after 3 weeks, I went down. I rotated that fragment and wired it and put bone graft. But to my utter surprise, after 3 weeks, there was a lot of callus. I repented doing that, but it's okay. Since I had gone down, I rotated that fragment, put in those wires, graft, and that was a fine surgery. But then there were these problems.
Amit, let me stop you.
Yeah.
With this experience that you have had, would you do similar thing today?
Sushrut, I feel this was a accidental case, a young patient. Yes, he threw good callus, but then all patients may not throw good callus, and we could repent for that 180 degrees rotated butterfly.
Will you do it today?
I will go down and do it. I will go down and put it back and put a wire there.
Don't give wrong message, Amit. Don't give wrong message. Entire world is watching. If you tell that derotate, you will devitalize the soft tissue. I don't touch. Just bring it to the bone. It will fine.
Yes. With a digital pressure from outside.
Even if you get it to the bone, you have to go down. No,
just pull it, push it, whatever you want to do it. Don't derotate.
I think I completely agree with Sunil that if you just go in a big incision just to derotate and match the cortex then probably you are doing more harm to the patient rather than good.
Correct.
Probably, yeah.
Just needs a small incision on the skin without disturbing the muscle architecture, and couple of K wires to derotate the whole lot.
Probably, look, all of you over here, I have, if it was a PFN nail, and if I was locking only in the lateromedial lockings in the distal fragment, then it would have been unstable. Mentally, I would not have been happy. Here, I've got good stability both the sides with biplanar lockings in anteroposterior as well as lateromedial lockings in the nail. So that was the fact that there was a good stability. If it was only a PFN nail, then I think, again, your choice of implant, you depend on the choice of implant, whether you have got good stability or not, and then you can decide about the rotation of the fragments.
Okay.
Can I?
Question to Amit, what Sushrut asked Amit, again I am asking question to Amit, whether you will do this thing again today or not, yes or no?
Not yes or no. Swarnendu, the thing is that I again told you it would have been my fixation, my mental satisfaction, the implant which I have used. If I was damn sure that both the sides have been fixed well, rotationally stable, and a good fixation, then maybe I'll not go and do it. But if I'm using a PFN, a proximal femoral nail, a long nail which does not have an AP locking in the distal fragment, I would go down and do it.
Derotating the fragment.
Yes, yes. I'm not mentally really satisfied and happy.
Okay, that's 5 months. Amit was very keen that I show this patient's video to all of you to justify his mistake.
This is at 5 months. 5 months, I have a recent video also, but then 5 months he was quite good.
He's done.
The next X-ray also, the next video, you have it?
Yeah.
Look at the movements at the knee. These are the knee movements. Because, retrograde nail, I had opened the joint, and even then the movements you get good. The thing is that the take-home message I would like to say, after doing a retrograde nail, immediately day 2, I start the patients on CPM mobilization. I put the patient on CPM machines because the patients themselves do not do it. A CPM machine really helps you in getting good range of movements at the femur. This is 1.5 years post-op and the patient is doing good.
Amit, tell the delegates far from to get this nail. I know far from to get it, but for the delegates you tell.
Where from?
Where from you get the nails for the delegates?
Yeah, this nail is available. Look, now this nail with the condylar screws, which I use, the condylar screws which get tightened from both the sides, is available only with one Gujarat person. He is Rajan, his name is Mr. Rajan. But you get Smith and Nephew nails also. Smith and Nephew does not have the AP locking in the proximal lesser trochanter, and they don't have the condylar screws which can get tightened from both the sides. But Smith and Nephew has got a good construct. They have got lateromedials and medial lateral as well as oblique locking nails.
Okay. So guys, the topic is still not over, and let me take this further now. Ipsilateral neck femur and primary bone loss. So it's not only rotated, but here I was faced with open grade 2 and segmental loss of this fracture. And of course, independent fixation, I chose to do 3 cancellous screw, and as Amit has done, a retrograde nail. So this was first generation retrograde nail, and I was faced with a huge amount of bone loss which was there. So there are choices whether we want to do a segmental bone transport or do grafting. I was not a very expert at segmental bone transport, so I chose to do tubular strut grafting and fill that void. And to my surprise, as years went by, it healed. But patient had another fall because of that short nail. Now what? Ashutosh, you want to take this?
The fracture down is united?
The fracture down is healed, yes. And the fracture up there is still healing because that's intracapsular, not healed as yet fully.
If it is down healed, then we can remove the nail and treat it as a fresh fracture on neck and along with the diaphragmal extension. Okay. We can go with the long DHS plate.
So this is what I chose to do. I removed one of the screws and I put another longer retrograde nail. Was an easier surgery for me at that point in time, and after 18 months everything healed well. So independent fixation, I chose to do a retrograde nail. Those days it was a first generation, it had just come in the market. Another example, this is how the patient came to me. An independent fracture up there and a failing shaft of femur which was treated somewhere else by plate. And so that's how patient came to me. So the options were whether to remove the plate and do something else, put a nail there, or just do grafting, remove everything and do nailing and grafting. I looked at the literature. So that time, ipsilateral neck and shaft, we used to do gamma nailing, and we published this data using a single implant for this complex fracture, and it worked well in those days because this was the gamma nail which was available. I looked at the literature. So if there is an undisplaced neck femur fracture, without much of displacement, or it was a incidental finding of neck femur fracture, you can use a single implant. If it's a displaced fracture, as Amit has demonstrated, then you need an independent fixation, and you have various choices. Of course, independent fixation either by a retrograde nail and something up there is the choice. If there is a displaced intracapsular or a basal type of a fracture neck of femur. So considering that this is the current consensus now, I decided to revise that. I was a little heroic. I put that fibular strut graft, which Amit Asgaonkar also likes. I put this time intramedularily, and I had screws going through bone, through the graft into the bone, and put some corticocancellous grafts also, and finally it healed. So that's 1 month down the line, 3 months down the line, 5 months down the line. That's 1 year's post-op. So you can actually use a fibular strut graft also if at all you need to combat with a late delayed presentation of hypertrophic or atrophic type of union.
Sure. Would you have done the same thing today? Would you approach it differently today?
No, I think I would do the same today. I'm completely justifying myself. So if there is so let's talk of ipsilateral neck and shaft. If it's an incidental finding, undisplaced neck of femur, today better designs of reconstruction nails are available. I would use a single implant.
Agreed.
There is a displaced fracture neck of femur and a difficult shaft femur.
2 implants.
Independent implant, 2 implants, and priority is given to neck femur and then do the shaft femur.
Yes, completely agreed. If it is an incidental finding, undisplaced fracture, single implant. If it is a displaced fracture neck femur, you have to go with the double implant.
The logic here for all of us to realize and believe is if it's an incidental finding, either you have created while hammering the nail in, or you have missed it because of poor X-ray. So it's low velocity trauma.
Less force.
Less force. So it will heal with that single implant which you use, reconstruction nail, and just holding that fracture because it's already reduced. It's not much displaced at all. So single implant would do the trick for you. You don't have to do fancy. But if it's a displaced neck of femur, you need today an absolute anatomical reduction and an implant which will hold your reduction, creating absolute stability. You know?
Agreed, ekdam. Clear message.
Okay, Swarnendu, your case, man.
Yeah. 20-year-old boy, traffic, Gustilo, this one, 3B sort of, distal femur with bone loss, patella fracture, and it was came from periphery. And can you go one ahead?
Yeah.
So this is the X-ray.
Sunil, you want to take this?
Sunil is there. Sunil is there.
First, I'm there.
Sunil is there. He is unmuted.
This is a grade 3 compound, probably.
Grade 3B.
Grade 3B. No, 3B. There is no neurological something, no neurovascular problem.
No, none. Obviously, I am not mentioning means that is for okay.
Okay, fine.
So there is a bone loss like Susruda's referring.
First thing is stabilize with the temporary external fixator. Give a thorough debridement, 1, 2, 3, whatever debridements you require, because the skin is crushed. So we need to excise the skin, whatever the skin is crushed. Get the healthy bleeding edge, and temporarily we do a lot of antibiotics coated beads here in compound fractures, and temporarily I will fix 1 or 2 cancer because it looks like just a split of the I mean there is no CT scan, but I would say there is a condyle just see one type of condyle intra-articular fracture. So just convert that into putting a 2 lax screws temporary, convert it into extra-articular fractures.
Then you put X-rays.
Then put an external fixator. And I would also put if there is a lot of big gap, I can put a antibiotic spacer so that it will give a little bit stability. And once everything is healed, I will pass on to, there are 2 options. One is a Masquelet, you can continue, or second is a bone transport.
So yeah,
Gurinder, what would you do? Gurinder.
So for me, I mean, how long after the injury is this? Within 24 hours?
just he came after, I think, next day.
Okay. I think, I'm going to go all out on this one. We've done a few, not too many of them, I hasten to add. So for me, this is the single day, debride the skin, debride the muscle, wash it 3-4 times, fix a joint, put your list plate all the way from the top to the bottom. Same sitting, going to put the cement spacer as in a Masquelet technique, a cylindrical cement spacer in there. Put a whack inside in the OT itself. Within 2 days, take him back, close in one way or the other. Whether you need you can put a skin graft, you can put whatever. But I would actually approach it like day one and go ahead. For me, the fixator is just a time buying thing. Won't really work in my hands.
Amit, what will you do differently than what Gurinder is suggesting? Amit.
Gurinder, yeah, definitely. I would not go for a fixator at all over here. Looking at the way the injury is, it's not a very, very bad injury, the skin injury. After debridement, it may open more. But then I would definitely go for an antibiotic-coated nail with a Masquelet, that's an antibiotic spacer, and treat it as an infected case, put in antibiotic beads, wait for it, and then do the rest of the procedures later after removal of the nail and bone grafting and the definitive fixation.
Ravindran and Ashutosh, would you do something different than what we have?
Yeah.
Ravindran first.
For me, yeah, the compound nature is not that bad. So obviously, take into consideration different. I'll put a couple of down into one, and now we have a gap. So I'll straight away put on an LRS. I will not do the lengthening now. I'll do an LRS. I will not do the osteotomy now. So I'll give it time for the wound to settle. Along with that, antibiotic beads to be added, and do the osteotomy later to get the bone transport.
Okay, Ashutosh.
I'll debride it, fix those condyles with the screws, then put an antibiotic cement spacer and X-fix. And within 3 weeks, of course, plastic guy will do plastic surgery depending on what is the tissue loss. And then after 3 weeks, depending on the bone condition, replace the X-fix with a long MIPO plate, remove the cement spacer and put a bone graft depending on the bone gap, cortical cancellous or a fibular stud graft.
What in the uterus? What you have done?
So we have just you have already advanced one slide. We have gone through the wound. We have debrided the wound, and we have. Can you go to fix these condyles? Next slide, please. So we have thoroughly debrided it, and also we have put the lateral femoral condylar plate as the in-X fix sort of scenario. Next one. Can you see that? Can you see that now we can see that it is like the in-X fix sort of thing.
Yeah.
Yeah. Then we have done the Masquelet sort of that the cement spacer. We have measured the length over there, and then we have done the cement spacer. We'll put in. Next one. Can you see the Siam picture just by the side of it? So I have put the Masquelet. We're planning for the Masquelet. So the cement spacer is there. This is the post-op X-ray. Can you see that?
Yes.
So this is like that. The patella fracture we have given one screw only, and we have put the lateral femoral condylar plate and the cement spacer over there. Next one. Second is the spacer remover. Then we all know how we go with the Masquelet. So you have to incise the membrane cautiously so that you can take the spacer very, very carefully. Don't injure the membrane that way. Next one. Then because this graft was, the space was too big, only the iliac crest is probably not going to hold. So that we have taken a part of the from graft with length from the medial side of the tibia. Next one.
Tibia.
Yeah, tibia, same tibia.
Oh.
If you see the tibia, and also you have given the graft from the iliac crest with some beads. Can you see here? If you see the X-ray on the left side and go to the extreme left corner, you will see there is a gap in the tibia. So that we have taken some part of the corticocancellous part of that length of the tibia, and that you can appreciate in the middle X-ray if you go to the AP film. And also
Yes.
in the right X-ray. Also in the right X-ray, you can see the white cortical line over there. Next one. Third stage, as because it was too big. Again, we have grafted this because we are very happy because that time me and my senior colleague Dr. Somnath Dey was also there in this case. So we both planned that we'll go with the another second stage grafting. Next one. Now you see 1 year follow up. You can see if you follow the principle how you do your Masquelet technique, you will see this sort of new bone generation, and also you see this sort of callus, and this is the 1 year follow up, and you can see the incision on the tibia. Can you see that in the middle?
Yes.
Middle critical photo?
Yes.
Yeah.
Big incision on the medial side, and also you can see the screws on the patella, and you see the knee bending and how the patient is standing and bending. So probably I think this is the end of all the follow up.
Sunil, yes, you want to say something since long
I
time.
don't think so. It is united. It is in the proximal prod. It is not united. It is does not.
It is
holding.
If you
Not united.
yes, it is
But
not.
taking a tibia is a very dangerous proposition. Taking a tibia is again a dangerous proposition. He will develop a pathological fracture of the tibia as well.
Yeah, because
And the Masquelet 2, 3, everything is that is a big amount of Masquelet will take 2, 3 type of bone graft. You can do the same thing by the LRS with the bone transport. No need to put a bone graft and nothing will happen. Right? It's a personal choice, of course. It's a personal choice, but I would say this is little bit more surgeries than the bone transport.
Parnendu, why did you think of putting the tibia?
Because when we started doing, because we didn't have that much of experience with the Masquelet technique. Now, because you see, the length of the defect was more or less like 8 centimeter, 9 centimeter, like. So we thought that.
Do you think the tibia would get, the cortical portion would get incorporated in the new bone formation?
As because this is completely circumference defect, only we put on the medial side. Rest it was filled with only with the cancellous
Then
bone.
why did the fibula and plus a cancellous bone graft?
No, only that time. That time we didn't have that much of experience. Nowadays, if you ask me today to do it, I will probably only put the cancellous bone graft.
Do you have any other follow-ups, late follow-ups?
No, last follow-up is this one. If I get that, I will definitely discuss in the next meeting.
Does he have pain over there?
No, there is no pain.
Okay, he seems to be comfortable.
Comfortable.
So, yeah, apart from that small gap over there on the lateral view.
It is not on the fold cortical union. Still, there is a gap at the posterior side. But if you see on the AP X-ray, I tell you, believe me, there is no pain at the fracture side.
Yeah. We believe in you. And in 1 year, this is the bone that is seen. Probably in 2 years, you'll see much more better bone quality.
Much more bone, yeah.
So, Dr. Samantha, we've had an experience of doing a few of these Masquelet, not a huge experience. But I can tell you the game changer for us is RIA. So RIA actually gives you almost about 2 bowls of graft from the femur. Very little morbidity. You just need to use the opposite femur. And you get actually enough. I can tell you this gap is filled up very, very easily just from the opposite side femur intermedullary graft.
I completely agree with Gurvinder, but the problem with the RIA, I think it is for the delegates, that the RIA remark starts from 12 only.
11.
It is very difficult to get the 11 one. It starts with the nowadays only you can get the smaller reamers. But when it was launched, it was launched with only with 2 mm.
But actually, you don't have to reach the isthmus. You can actually go short of the isthmus and actually take it. So even we thought we would never be able to get it. We always use the smallest reamer in that, as you rightly said. But we don't even go to the isthmus now. So we even just before the isthmus also we can pull a lot of it.
Okay, RIA is a good option. So this is another one. RIA is really a good option for your massive defects.
Parnendu,
Yes.
would you ever think of removing the implant in these cases? Or any one of the panelists has removed implants after Masquelet bone grafts and Masquelet bone unions?
Anybody? Ashutosh?
I don't remove the implant, still it causes a problem because I use fibula strut grafts. These are mainly tend to fracture in due course. So I don't remove the plates.
Why you will Amit? Why you will remove a locking plate? Because if you remove a locking plate, there might be fracture itself.
You are right, but anytime later, even if it is a nail or whatever implant it is, masculine bone unions are my point of is that the bone union and the callus formed in masculine is not very strong. If you remove the implant, then you will have a very bad time. It may refracture over there.
Yes.
Sunil, what is your opinion?
Refracture is a very high chance probability.
Sushruth?
Yeah, I have never removed implant. I dare not, honestly.
No, keep it there. Keep it there. No point in adding another one complication.
Yeah. Okay, let's move on. Amit, your case now.
Yes.
Tell us about this.
Yeah, this was a 42-year-old fall. He came in the night. He was drunk. He had another fracture, very complex olecranon, which I'm not showing because we have a lower limb trauma. And this was the injury. I think we go ahead with the CT scan. Yeah, this is the CT. Yeah. Next. Yeah, so this is the CT.
What did the just read the CT for us, please? We can't.
There was a posterior. Mainly, there was a posterolateral element, as well as a posteromedial fracture, which was not very much depressed. It was generally, you know, that the posteromedial is a good condyle, is a better condyle, which has got two nicely identifiable fragments, which you can buttress very well. And on the lateral side, most of the times, because of the lateral tibial condyle has got a concavity, it shatters. There's a lot of combination. So the lateral side, there was a combination, but in this case, there was more of a posterolateral combination. And let's discuss first. So we should go back to the slide. CT, yeah. Opinions of the panelists. What would you do?
It's posterolateral extending onto the medial condyle. That is posteromedial. It's extending on there. It's more comminuted and depressed on the lateral side, but there is a line extending on the medial side as well. So obviously it needs a posterior approach.
Yes. But what approach? Only one approach? Would you go in for a single central approach? That's a lazy
yes, single approach on this because it's running from lateral to medial all the way through. Yeah. And there is a depression. So which can be tackled with all with
you go with the inverted L incision, which you can convert it into a lazy S.
Exactly, the original type which we used to do, either the lazy S or the inverted L or whichever.
Yeah, but Ravindran, with the inverted L or with which can be extended to the S incision, it's a bit difficult to put the posterolateral plate. You can definitely go in with a separate window on the lateral side, retracting the lateral gastrocnemius. The lateral plate would be a small oblique plate only over there on the posterolateral. Here there's a big posterolateral element which needs a good elevation and a proper buttressing. So I thought otherwise, because with the central incision you can approach both the sides, but I feel the posterolateral is compromised. If you have a majorly a posterolateral component, then you have to fix the posterolateral by a separate posterolateral incision.
Amit, I know what you have done, but still I'm asking you, why not take two independent incisions? One is approach.
I took two independent incisions.
You took?
I took two independent incisions. First, I started with the posterolateral, which is there on the next slide. Frosh. And then I did the inverted L also. And so I put a posteromedial incision also, a separate one. Swarinendu, what would you do with a single approach or a double approach?
This fracture cannot be dealt with. This fracture cannot be dealt with a single approach. In my experience. Somebody who is experienced, I cannot tell that in my side. But because the main depression is on the lateral side, you have to elevate that fragment and you have to neutralize that. You have to elevate that and you have to buttress that lateral fragment first. And the medial side is less comminuted. So medial side is not the big problem. Main problem is the posterolateral condyle. So I will do the lateral side as well as the medial side, two approach.
Two separate. Gurinder?
Two separate approaches. Nothing need to do the
Yeah.
frost. You can tell the medial one. You can actually go medial to the medial gastrocnemius. You don't even need to do an L. Just a vertical one would do.
Sunil, do you think differently?
No, there are two ways to do it now, because if the lateral side going into a lateral side from that posterior L shape is extremely difficult. The Low's approach from the posterior median and go, it's cannot come. But I would go for a frosh approach rather than to go any person. So two windows, frosh approach, elevate, or now we have recently started what given by Crete, the anterolateral, the fibular osteotomy, and also to go chop off the IT band and get the complete elevation. So that is also a good approach. We have a couple of patients. Both gives excellent.
Yeah. But that is more of a lateral, posterior lateral only.
Posterior medial, I use a small buttress.
What Sunil is talking about is anterolateral approach, Cretex.
Lateral approach, so that you can have.
It is talking about the fibular head osteotomy along with the IT band. Which is
So the entire thing, Cretex has, if you remember, Cretex has given this demo in the cadaveric workshop as well. In Mumbai Trauma also he had given this.
Yes.
So Sushrut, one thing I want to add, and just for the discussion's sake, now there is an approach that is the extended suprafibular approach for this. If you want to go back and front on the lateral side, so if you go with the extended suprafibular approach, you don't have to take now the fibular osteotomy is coming less and less. So if you go with the extended suprafibular approach, it is just the modification of the frost one. You can go posterior, and you can go from is a parafibular approach also. So that you can
put a lateral plate also.
You can do the back side, you can show on the lateral side. Extended suprafibular approach.
Kufri has decided to discuss that in details. He is the one who is modifying the Schatzker's classification. Kufri.
Yeah.
Okay. So shall we go ahead, Amit?
Yeah. Go ahead. So first, initially I started, this was in the prone position. Next slide also, Sushrut. This was in the prone position. I started with the posterior lateral first. That was the common peroneal, which was running straight. It was not running straight along the biceps femoris. Generally, you have to identify the biceps femoris, and along the biceps femoris, the common peroneal runs, and then it comes down. It turns around the fibular head. Somehow there was a variation in the anatomy, and the common peroneal was oblique in the popliteal fossa. Fortunately for me, I didn't cut it, and I identified it, and I could reflect it. Next slide. And I went down, and this was the way the posterolateral element was initially elevated from the posterior side. This was the buttressing plate, which was put from the posterolateral aspect. And then I did a separate posteromedial incision. And the next slide, Sushrut. And this was the follow-up of that patient. Only posterior platings, posterolateral and posterior. Sushrut, this is the video. You'll have to run that video.
So this video was not getting loaded.
It is not okay. The patient had full range of
motion. Full friction. I saw that. I can vouch for your competence.
Yeah.
But one thing is the lateral side, the plate is too down and too dangerously plate.
Yeah. You're right.
Because I think what Sunil is pointing, this is for the delegates. When you go with the posterior lateral side approach, please don't go beyond 5 centimeters.
6.
So if you go beyond 5 centimeters,
magic number is 6. 6 centimeters, and your artery is crossing.
That's why I am telling you 5. 5 is the deadline.
Safe line. Yes, correct.
Sunil, it is a longer plate, I believe, but then it is not down. I could see the subchondral, the joint line, and I put just below the joint line. Because there was slope, that's the reason you are seeing like this.
Big plate is not necessary.
Yeah, it is not probably necessary. But then the apex.
Go at 6, you will meet the trifurcation. 6. So don't go to the 6. It should end at 5.
It's extremely difficult to calculate, so it's better to use a small 3-hole radius plate. That's it. It will solve the majority of the problems.
I agree with Sunil.
Yes.
Okay, Ashutosh, you're on.
Yeah, this is a 25-year-old male, had a accident, open fracture of right leg with loss of tibia, almost 10 centimeters. There is an open wound anteromedial aspect with soft tissue loss. Neurovasculars are intact. Patient came to me late, so we don't have clinical picture, but this is the X-ray picture.
Sorry, Asutosh, in between my internet connection was somehow from my side or that side. I could not listen to the beginning of this thing. This is this you just told. This is a fresh injury. How many days?
This is fresh injury with open fracture, loss of tibia, and wound on the anteromedial side.
Okay.
Ravindran, what do you want to do, man?
I think the same thing what I explained for the femur. So this is debridement. I don't know how big the wound is, so probably needs a flap or a free flap. That I'm not sure without looking at the wound. So either way, the wound is going to be taken care of by the plastic surgeon. So temporary external fixation is the one, and once the wound is settled, I'll go for a bone transplant with the LRS.
You fancy LRS too much, is it, Ravindran?
Yeah. I'm happy with the LRS. Yes.
Everyone over there in Tamil Nadu and South, they are very fond of LRS.
Ravindran, let's talk about North. What's happening up there in Delhi?
So I don't think LRS is as popular as it is in South. I think, for the tibia, for the tibia, I think I would like, I'm not had good results using Masquelet in the tibia. So, I mean, I'm going to go for an external fixator as well. My take on this would be, I can't get the LRS to work very well. I cannot get my bone transport to go in the direction that I want. And I'm actually much more keen to use something like a Ipsilateral kind of a device, a circular frame with the multiplanar fixation.
On the first day.
Amit,
pretty much on the first day, yeah. I mean, in concordance with the plastic surgeon.
Amit?
I actually, as Ashutosh does not have the clinical pictures, I think debridement and probably in this case, with such a big bone loss, I think Ipsilateral is the best option over here.
Sunil?
Ashutosh, when you present, we have to have a CT scan.
We don't have CT scan, sir.
So we have to.
It came to me very late.
Because if it is intra-articular extension,
there is no intra-articular extension.
We have to reconstruct that either putting a 6-4 mm cancellous
no,
and convert that into a extra-articular, because there are hardly any space to pass the even wires.
Yes.
So I will extend the foot frame with the Ipsilateral fixator. I will put a fibular nail, the fibular nail. So one column alignment.
At least one
very
column
important.
intact.
So that you can have an internal bone transport easily, because there is a high chance of diversion when the both columns are fractured. So both columns should be one at least. Either you can put a plate also. There is no problem about the fibula, but at least you can put a nail because it is a compound. So if you put a plate again, there is a high chance of infection. So one column and then rings and go below the foot ring, so that it gives excellent stability. The small fragment of the distal tibia. Hope it is extra-articular. If it is extra-articular, then you have to convert that into an intra-articular to the extra-articular and then plan it.
What about the defect?
Differently that you will do, Swarnendu?
No, the problem is the soft tissue. Problem is the soft tissue and the bone loss. So you have to know. I will go with the Ipsilateral.
Okay.
Sunil, if you put the fibula nail, how are you going to distract and compress later on?
That is not that we can do it later, because it's
But I like that idea of fibula height reconstruction, length. Because that will be your reference, you see, all the time.
I understand, yeah, that is true. But then the primary aim is just to stabilize and control over the
stage. If at all you want to do, you can do fibula osteotomy up.
Yeah. You can do an osteotomy, but compression and distraction over an intramedullary tibia nail is only better.
There is a very small fragment, small fragment.
Yeah, I know distally there's a very small. Anyway, what did he do? Oh, Masquelet.
So he got debridement done, cement spacer with antibiotic and Ipsilateral fixation. This is on November 2016.
And he's put the foot in the frame as well, which is a good idea.
Yes. So can we go back?
Yeah, sorry.
So that has an anteromedial defect which was persistent. So now, if a plastic surgeon has to, with this so much defect, with anteromedial skin defect, if a plastic surgeon has to come into play, and because he may require a rotation flap or a cross-leg flap or a free flap, so how difficult will be for with a laser off frame?
Ipsilateral frame is not for good, not friendly for the plastic surgeon. You cannot, with the plastic surgeon, you will be the most unhappy person to be referred for plastic surgery job.
No, you can change the threaded rods. You can change the threaded rods because he is not going to walk immediately. So you can change the threaded, keep the whatever the flap area they want to keep it within. You can change the threaded rods. You can tell them. You can increase one more shank spin in the near the fracture side and increase the strength of the plate so that you can change the threaded rods differently. So you can put it separately so that it gives more space so that the plastic surgeons can work it out. There is no way we have to do that. And the
Because
Masquelet
what we've done is exactly what Sunil has said. We've left them free rings. So
Yep.
we haven't attached the distal fragment. We just left it free. The fixation was above and then into the calcaneum or something. And the center portion, we just left the ring in there. They came and did it. After they finished, we've gone ahead and put some wires and all because they need to anastomose with the posterior tibial artery in there.
Yes,
So you
right.
need to leave that posterior tibial column free.
Ashutosh, you did the antibiotic spacer with the intention of putting a bone graft in the masculine membrane later.
Actually, this was done by some other person,
Okay.
but that was the intention of the surgeon to come in the second stage with the grafting.
But generally, in tibia, it's very difficult for
Yeah, it is very difficult.
the masculine.
Yes.
Let's go ahead.
So in November, at 6 weeks, he got the iliaceral removed, cross leg flap was done, and X-fix was put to protect the flap. Antibiotic spacer with fibula rod was maintained.
Okay.
Then in December, 7 weeks from the RTA, the flap was detached, and this was his X-ray picture. Can
Any
we go
clinical
ahead?
pictures?
Yes,
Ashutosh, any clinical pictures of the patient?
we have, because the patient came to me late. So patient was asked to come within 3 weeks for removal of X-fix and definitive surgery, but did not report on time due to financial problems. But on 3rd April, that is after 5.5 months of RTA, he came with this X-ray picture. Next. Now this is after 5.5 months. This is his clinical picture.
So now the patient is with you now, is it?
Yeah, from this point he is with me. He is with a slab also. The flap is good, supple. You can see the size of the flap.
We'll have to add a foot frame also, foot frame or a foot ring.
Yes.
Okay.
And we'll see the X-ray picture. Yeah. So what are the problems and how we can go ahead from this part?
It gone pierced through the lateral side.
Yeah, it is loose. Can you go back one place?
It's actually loose, you're right.
You can see on the top side of the rod there is a cotton piece. Clinical picture. That frame is totally loose and that rod tip is hurting on the medial side of knee. It was so loose and also infected. That's why there was a slab also. Next, please.
Okay.
So how to go ahead?
So this was how many months with the
6 months.
antibiotic?
5.5 months.
6 months now.
So the antibiotic spacer was there. Now it is acting as a foreign body.
Yes. The pin track is also infected. Knee is stiff. Ankle is inclinus. And if you see the distal fragment, distal tibia, it is osteoporotic.
So Amit, what will you do now? Sunil, we are also hungry, man. Amit, what will you do?
Now I think I'll remove the whole thing. I don't know how much of Pintrax infection is there. I'll remove that antibiotic spacer also. I don't think the antibiotic spacer is just keeping the tibia ends apart. It is not serving much purpose now. Remove the fibula nail also and put an antibiotic rod inside the tibia.
How to get a hold distally?
Hello?
Distal hold?
You'll never get a hold, Amit, distally.
I do understand. I'll not get a distal hold. But
It's a
then
paper cortex.
Again, we apply the iliaceral fixation.
Iliaceral fixation.
There is no other alternative. You have to again do and then
Okay.
bone transfer.
One request by the patient, no iliaceral.
Death before Elizaro.
Now you do a LRS now. Ravindran.
LRS is not going to be easy. Now it's not going to be.
antibiotic rod there.
Let's go ahead. Let's see.
So I think in our 2 points, whether biologically this induced membrane will work or not.
After 5 months it will
Not now. It is. I don't know now since you're showing it, but then I don't think it should work now.
Fibulectomy or tibulation of fibula, any option? Or if the if the good membrane is there, we can go with RIA. Only problem with low hemoglobin, and if there is an infection, the resorption of this RIA is major problem. And amount required to fill that gap with the RIA is most difficult.
Presently, I think an antibiotic rod with an Ipsilateral frame for stabilization and removal of the rest, all the rest of the things.
Okay.
Amit, are you putting a rod from the calcaneum up?
So problem is
Not from the calcaneum. I do it from the tibial condyle into
there
it.
is no
K-nail or a
flexion.
K-nail and an Ipsilateral frame added over there.
There
Fresh
is
one.
no knee flexion at all.
Good idea to do the retrograde nail on the retrocalcaneal nail.
Yeah, that can be good.
So you pass it through the
Ankle
transfix.
is already gone. Subtalar joint is also must be gone.
Absolutely. I
So
think
what did you get over here? The antibiotic sir.
Amit, he's got a stiff knee. You won't be able to get a nail.
There is no movement at all in the knee.
Suprapatellar. Anyway, yeah.
So I did not have any option. There was no knee flexion. The flap was supple. So along the edge of the anterior edge of the flap, I removed the spacer. Next. And I used the fibula strut, almost 12 centimeter, and use a medial locking plate below the flap, in between the membrane and the flap. Also transfix the fibula below with the locking screw and at the upper end with a cortical screw, and put a ilectrous graft at both the ends of the fibula.
Ashutosh, this was done all these things in the same sitting?
Yes, in single sitting.
And no infections you were found?
No, I removed the X-fix on the first day when I see him, and waited for 5-6 days, and then I had gone ahead. Any comments on this?
Ravindran.
This is good. This is good, Ashish.
Next
This is
slide.
one option, yeah.
So this is 6 weeks. The question is it a correct method with this long standing with 10 centimeter masquelet? Can induced membrane will accept the cortical graft, and that too so late? And what are the chances of non-union and at what level?
There is no induced membrane after one month. It's all fibrous tissue. There is
Yes.
no membrane, there is no totipotent cells, nothing remains there after 1 month.
So we are expecting this graft to fail.
And the graft, induced membrane, you said, Ashutosh, will not accept any cortical graft, by the way. It will accept only the cancellous grafts.
Yeah, that's our question. Is it
for
a
just
correct
support
method?
and length. And unless that induced membrane is no longer an induced membrane now, it does not have the potential to form.
Potential to, yes. So the plate is going to fail, or the fibula will fail first.
No, why either of that should fail?
Because if
No,
the
why
fibula,
will it fail? You have done a good fixation. Wait and watch.
So are you giving it protection with a cast
no
or a
protection,
brace?
nothing. He was just mobilized with knee flexion and ankle movements.
And weight bearing status?
After 6 weeks, I allowed him to partial weight bear. Next
Infection
slide.
cleared.
Infection cleared. Can we go ahead?
Yes, go ahead.
Yes, so this is at 3 months. So rationale was I usually put a cancellous graft at both the end, and late presentation I use a strut graft, and strut was drilled at multiple levels at different directions for bone ingrowth, my thinking, and cancellous graft at both the ends, and strut was like a peg which was inserted in medulla on both the sides for better cover. Next. This is at 3 months range of movement. Little bit wound dehiscence was there, but it healed over a period of time.
He has good function.
Yes, he has good function now.
Yeah, it seems. What did you do to the ankle?
I started to mobilize him. That's all. No physiotherapy like special. Can you go on? Yes. 6 months walking, partial weight bearing with a stick. Next. 7.5 months and 9 months, it is gradually consolidating. Next. And this is, he is walking with a stick, and this is his range of movement.
So you have to correct his equinus now.
Yeah, we have to correct his equinus. How to correct that?
Either a tail lengthening or you can do again a foot frame and put a other alternative.
It has to be gradual correction at that.
Gradual correction, yeah. Can you go ahead? Yes. So this is a fantastic article, Masquelet technique, myth or reality. Meta-analysis, all of the articles. Next. So there is a few studies with a spacer duration. There are only 4 studies with more than 12 weeks of spacer duration, but the studies are there. If the spacer is more than 5 months old, it still works. Next. And it also has studies with additional fibula strut graft. Only 3 studies. Even Masquelet has 3 cases. Kager has 7 cases. And if we combine those, we don't know whether it will unite.
Beyond 6 weeks, he has given it up.
Yes.
But
And 1 year,
this
Yes.
is for tibia or femur?
this is all, they don't segregate. There is no
Because
segregation in that.
femur has got a lot of soft tissue envelope there.
Yes,
Tibia
yes.
is more or less a subcutaneous bone. It's very
Subcutaneous
difficult
bone.
for the tibia to heal. And
So the story doesn't end. Now, if you see on the right side of the image, is it disintegrating, consolidating, or sequestrating?
It is disintegrating
Disintegrating.
in between.
So should we intervene at this level again or wait?
infection? No.
No, in fact, a little bit at the flap edges.
You've got some
infection.
scarred up areas on the anterior aspect.
Yeah,
which are
but
looking
he is walking.
suspicious.
Even you can see the fibula, it has become hypertrophic and it is getting connected with the other fibula graft also.
That's
Now you
important.
can think of fibula pro tibia, you know.
Yeah.
Very important aspect that right from the beginning, the fibula column is intact.
In fact, yes. The
Surgeon
first
has-
day the fibula was nailed.
Good column stability.
I removed that cortical screw. And next slide. And this is the final follow-up at 3 years.
That's good.
Very good.
He's walking back to work. Unfortunately, he's a criminal, but
So this is very,
what
very,
about-
very impressive.
So has he gone back to his profession?
no, he has a lot of summons with railway police, so he's still.
Ashutosh, what about his ankle?
He got almost 5 degrees of dorsiflexion now.
Infection.
He's
On
happy,
his
but
own. And the knee?
knee full range.
Full range. Very
Full
good.
range. He doesn't want any surgery anymore now.
Very good.
Yeah, yeah.
So you
Very
have,
good.
your patience has worked. Yeah, good.
Very nice.
Ravindran, yours.
Yeah, this is, it's not a 70-year-old, it's a 65-year-old fellow in
You only sent me.
2008.
I
Sorry?
didn't modify. You only sent me.
That was my mistake, Sushruth. It's okay. Close the door.
So he's a diabetic, he's a smoker. As you can see, the thing is, I can't say it is whether closed or open because the initial treatment was all done elsewhere, so I don't have the picture. But I presume from the wounds which were seen after when he came to me, and the wounds were closed, it looks like open injury he had. So this was the position. How will you manage?
Gurinder, what do you want to do?
Okay. So if he's come acute now, we're looking to try to start fixing it. The only thought in my mind is, do I have the time to get a CT scan or not? Going with the idea that it doesn't have a vascular or neurological issue. So do I
No
have
vascular.
no vascular, and the skin is not too bad. As you said, you can't really comment on that. Okay. So I think I'm going to go with the idea of going for a definitive fixation. So the definitive fixation, I'm going to start maybe on the femur, I think, and I'm going to go with the idea of putting a lateral plate, fixing the joint to the proximal. There is an intra-articular piece that you can see. So go across, fix the intra-articular piece, connect the plate, leave the combination as it is. I won't look into doing anything presently. Then I would go and proceed towards the tibia, go for biplanar fixation. Now it all depends on how he is systemically, how's the condition of the skin and all. But essentially, if he's reasonably optimized, go with the idea of doing everything in the same sitting. So femur lateral plate, dual fixation of the tibia.
Varnendu?
Yes, this is a floating knee scenario. So I will agree with Gurvinder, but thing is that I will start from the tibia, because I will start from the tibia. I will fix the tibia, then I will fix also the tibia, also the femur and all the long locking plates.
Is there any logic why femur first or why tibia first?
Because when you put the if you keep the X fix during your fixation, you are safe, that you are not pulling traction, you are risking your vessels. But if you not keeping the X fix and you are just fixing the femur, then inadvertently sometimes you may pull your great vessels. So I will take the tibia first, then go to the femur.
Ashutosh?
I'll put a X-fix first, and when the wounds and all soft tissue swelling is good, with the X-fix on, I'll put a tibia plate first and a medial side short plate. Then the second surgery, I'll remove the X-fix and put a MIPO plate for femur.
Amit?
Masquelet.
I would do differently. For the femur, of course, X-fix and all those things are different. And once the whole thing is quiescent, I would do a distal femur nail through an infrapatellar approach. Distal femur nail crossing the. I don't know whether it's closed, it's fine. If it's open, it's a different procedure, because I would be entering the joint.
Wait. Let's say it is open. What will you do?
If it is open, then
X-fix.
yeah, of course, X-fix first. Wait for the infection to clear and the wound to close, and then even then, and if it is not connected to the joint, I would, in this case, do a bipillar plating for the tibia and a distal femoral nail for the femur.
So let me ask you, Amit, we both agree on one point, that internal fixation definitively done will enhance early wound healing and better fracture fixation.
Yeah.
Okay. So what is your cutoff point to decide that this wound is okay to go intra-articular to put a nail in?
For me, if it is not connecting to the joint, even if it is connecting to the joint, and if the joint is infected.
No. Amit, compound injury connecting to the joint, but it's a fairly clean wound. How much clean? What is your parameter to decide that this is clean enough, though it is entering the joint, for you to consider a definitive intra-articular, intramedullary, retrograde nailing?
I think apart from all the neurovascular injuries, and if you are really confident about your debridement, about your own debridement, after doing the debridement, I would go in for a definitive intramedullary nailing. I would not find any problem over there.
What I wanted to bring up, because if the wound is good and you have done the debridement and you are confident about it, why not consider primary retrograde nailing?
Absolutely. This has got enough space in the distal fragment. There is good bone stock in the distal femoral fragment.
Yeah,
it could hold 4 screws.
Absolutely. Because you can use the same approach to put retrograde nail, same approach to put the tibia nail.
Yeah. In fact, yeah, exactly. Sushruth, the infrapatellar nail in the tibia would not work over here. Probably this is what, in fact, the joint, if it is infected or if it is open,
if you are not confident and very comfortable with the wound situation, then it's a different ball game. We are not talking about that. But if you are comfortable with the wound situation, good debridement, clean wound, even though it is extending intra-articularly, let's go ahead with definitive fixation, good stable fixation, and then it will take care of, if at all infection happens also, it will be, you can take care of it more aggressively. Sunil, you wanted to say something?
I think this is intra-articular, there is a HOFAS there, because I am not clear about it. So you have CT wellness?
No. No.
AP view, there is a double shadow. So if there is HOFAS, all this intramedullary nail, everything will go off. So we want to doubly sure that there is no HOFAS. If it is HOFAS there, again even the tibial plateau has a split on the medial side as well as on the lateral side. There is a depression on the lateral side. So you need to have a good CT to decide what are the things you want to do it. And if it is compound, you have to give other parameters like CRP, then infection, other parameters. We have to see the WBC count routine. Everything should be seen first. Put a whack on that, and then you can plan it.
Sunil, considering there's no HOFAS, just an intramedullary, intra-articular small split in the distal femur, a C1 type of fracture without any combination, what would be your choice of implants in both the cases, in femur and tibia?
I am always using now the dual plates on the both sides, on the lateral side.
In femur as well as tibia.
Femur, tibia, both sides. I am now convinced
Such
that
a long plate, Sunil, there's a lot of combination. The working length of the fracture and combination is very high, very long.
So that's what the big long plate till the trochanter on the lateral side. Now
Bridging.
we have now for this patient, I would have done the endorsnel on the medial side because plating on the medial side looks difficult because the artery comes with the 10 centimeters near that. So plating, anterior plating can be done. We have tried anterior plating, but I will use this locking plate on the lateral side and the endorsnel on the medial side, and bicondylar plating for the tibial plateau.
Other thing is reaming of the proximal fragment of femur. The canal is very small, so that will disturb the other middle fragments also.
Canal looks small because probably the X-ray. This is not a very small canal. The patient is around 70-year-old, 65, 70-year-old.
65, yeah, 65, 67, yeah.
What did you
do?
Vella, what did you do?
Well, I didn't do it anyway. Okay, this was acute presentation, and it was the first. I'll tell you when I was involved anyway. So this was done elsewhere in 2008. This was the thing which was done, a short IMS. So short nail was done. I think in 2008, most of us were doing 2000 and the short nail. It was converted to long nail one day after 2008 or 9, something like that. So this was the thing which was done, and then a plating was done on the tibia. The wounds were it was a healed wound, what I saw, which was about 2 centimeters probably on the distal femur and about 2 centimeters on the proximal tibia. So when he came about a year down the line. You can see that 8th month 2009. That's the time he came, 1 year down the line, and he was walking obviously non-weight bearing, not much of weight bearing, and the knee movement was about 70-80 degrees. And that's the question now, what to do. I was thinking about revising the nail, then plating, then bone grafting, whichever. The tibia part is sorry.
Actually, if you're doing the retrograde, I think you should not call this a supracondylar nail. It's a distal femur nail. Now, these distal femur nails, if you do this is not a good idea. Then I would have gone with the Sunil's idea of a long plate and an enders nail from the medial side. This will not work much because of only 2 plain lockings.
Did you say a nail with an enders or plate with an enders?
Plate with enders.
Plate with an enders.
Plate with an.
Yeah. Enders from the medial side, Gurinder.
Yes.
Yeah.
I think
so. When I suggested revise it, so he went off in 2009. We'll have the next slide.
Yeah.
Sunil, you'll have to unmute yourself. I think he's trying to say.
Then he comes back in 2012. That was 3 years down the line.
Oh.
It was done about 60 kilometers away from Coimbatore. So in the meantime, you see that the tibia is united quite well.
Yeah.
He is maintaining that distal femur nail, the short nail, and that has been now 3 years. It was done in 2008, so it's about 4 years. And I said again to do the same thing, revise it.
Does he have a pain?
Well, the pain is not that much. The wound is settled. His range of motion is coming to about 90 degrees. Only thing, he's not able to fully weight bear. He's walking with a stick with an aid. Obviously, there's gaps in the bone that you can see.
Yeah,
so once he starts weight bearing, the story can change. So this was almost like 4 years down the line. Again, I mentioned that and he didn't want to do it again. Next slide. Now he comes back in 2015. 2012, I saw him again. He comes back in 2015 in January. In the meantime, what I heard that he had a second surgery with a bone graft, with a G-bone. You can see that. On the left-hand side, you can see that. All the G-bone bits and pieces. And, autograft was taken from both iliac crest.
So same implant, but just added bone there.
Yeah. Even at that time, it was not revised. So 2008, it's 2015. So 7 years down the line, it was still not revised. Only the bone graft was added, G-bone with the autograft. And then you see it on the right-hand side, a few months later, then he comes back with a broken nail.
Oh, this had to happen. He was walking on that nail.
Yeah. I mean, he was walking on the partial for 7-8 years. And then it's given way.
And it is united.
Now,
Sunil, it does not seem to have united.
it will unite.
so now I said I'm going to change the nail, and I opened it up. It was only a shell of bone, very thin bone. It's all scar tissue and fibrous tissue. Lot of G-bone, as you can see there. It was doing nothing. This is one example that the G-bone doesn't do anything. It was all lying, and we took out all the bits and pieces, debrided whatever we can, then put a longer nail.
How did you remove that distal part of the nail? Open the joint.
Quite easily. I mean, I was there. You can see that fractally opened up. Quite easily came out.
Okay.
So once we've done that, I put a Proximal lock. Didn't lock it distantly. And I want to lengthen the bone because there was a big gap. Which is only a thin film of cortical bone left. So I want to lengthen it. So put on LRS with the small size nail, as you can see there, to accommodate for the shank spins. Now this one was done by me. And I was able to get a centimeter and a half lengthening, as you can see, 2015.
Speakers. Hello.
Sorry.
You're using two speakers. Use one mic.
So 2015.
Ravi, did you lock distally, that distal femur?
No, I didn't lock distally, intentionally. Because I want to lengthen the bone there.
Okay.
Osteotomy, and I'm lengthening the bone. I have to control the LRS. But the thing is, next slide, he doesn't want the LRS. He was uncomfortable with that. Round about 4 months down the line. So he wants the LRS taken off, and I got about a centimeter and a half lengthening. And once I left the nail in situ, now you ask the question: was it locked distally? It was not locked distally.
There is one thing, Doctor Amit Agotar and Dr. Velaswamy, are you using the same device or what?
No.
Or are you seeing some webinar?
No.
Audio is not there.
Audio is
It's too much echo. We cannot. It's really problematic.
Oh, right.
Somehow your mic, otherwise it went well.
Somehow somebody is.
Yeah, now you can see it.
No, it is too much echo.
Too much echo.
Please, sir.
Balasamy is muted.
Yeah. Anyway, I'll continue.
Okay.
Okay.
So exchange
So
nail, exchange nail.
And that was the exchange nail. And once having done the exchange nail, a year later, he was doing well, but a year later, he started getting fever and he came to the OPD as a toxic patient. He was having pus which was coming out. And now he's almost like 10 years down the line from the original fracture. So what I did, I took the nail out, I debrided and just put the back on. Give me some breathing time to think what I have to do, because I was advising him to have Elizarov quite a number of times, which he did not have it done. He's refused any external fixator, any Elizarov that that's how he is. He wants anything internal. And now this is the situation.
Okay, Sunil, you want to say something?
Yeah, right from the throughout, it is unstable fixation. Even that nail is also very flimsy. Once you remove that broken nail, you should have plated that, because it's a non-union. You are not giving the absolute stability. That's not going to unite anything, whether you do LRS or anything you want. So you should have united first. You tried both sides, first union and then lengthening. So at least the main concept is to give first union and then you lengthen it later if patient wants, because the lengthening is a different ball together. If now both sides go into non-union, it's extremely difficult. Now, if the infection is through, I would plate it properly, both sides, put a condyle, put compression on the both sides, give absolute stability, and then mobilize. If there is
now it's infected.
If there is no infection, then
now it's infected, Sunil.
Then infected, then put a beads, put a intramedullary nail of a vancomycin coated nail, and give him some cast or something, so that he will stay, because he will not be ready for any external fixator now. He's fed up. So give him
now the joint also would have got infected by this.
It's already gone, because the nail was already migrated inside the joint.
Yeah.
The joint is already screwed up.
I mean, what do you do now?
Fire. Hello?
Yeah, tell me.
I think the joint is fired. I don't know how much range of movement you got remaining in the joint. Yeah.
How much it is remaining? We'll just see it in a while. How much we'll get, because he started getting swelling in the joint as well. So obviously the pus is coming from the distal femur. It's probably tracking in the joint as well. Yes, I agree.
Because the track of the nail is there intact, so the pus must have gone inside the joint as well.
Yes.
Most of these fragments over there are infected, the lower end of the femur. So you'll have to debride it properly. Probably all those loose pieces will go off.
Yeah.
Any suggestions, Swarnendu?
Now, I think the problem is not the bone, also the infection is the main issue. So I think what I agree with Sunil, how we went through with a smaller thing, intramedullary fixation, and also that now we're not going to back to this, but now this is a really problematic issue, because he is not willing any sort of external fixation. So I will go with the antibiotic rod inside.
But where is the hole, Swarnendu? Only in the distal femur, or you will cross the joint?
We have recently started. Can I add, Sushru?
Yes.
You have to go with the antibiotic rod only.
Locking plate as an external fixator. The locking plate is outside, and the screws are bigger, so that it will act as a locking screw as well as a locking plate. It's a long locking plate with as an external fixator. This is the only best solution for this patient. That's what I think.
But Sunil, he does not want an external fixator now.
The locking plate itself. The plate itself.
The plate is outside the skin, huh?
Outside the
Amit, he doesn't want it for the last 9 years.
Yeah.
And now I have to convince him for something else.
What Sunil is telling, the locking plate as the external fixator, that is a long screws.
Correct.
That is there in the literature. The thing is that, but still please say the locking plate external fixator.
It's a locking plate.
Yeah.
Yes.
The plate from outside.
It is mostly done for the tibia from the medial side. Mostly done for the tibia from the medial side.
Gurinder, any idea you have?
So I think I'm going to go with the idea of packing it with a lot of stimulant, putting a whack on the outside, and using an antibiotic nail, whatever stability it gives. I'm going to go with that.
I am with the antibiotic nail.
Okay, Ashutosh, any suggestions? Different?
If he's an old person, we should discuss with him and we should think of a arthrodesis option.
Okay.
If his knee joint is
What did you
infected.
do, Ravindran?
Now we'll have the next slide. So it's 9 years. Before that, previous one.
Arthrodesis.
So it's a question of whether going for an amputation because the patient was toxic, fever, all these things. No stability. So the VAC was not working and there was continuous sepsis. Then I convinced him, your leg, your life, all this in danger. You want something else, which is Ipsilateral, which is right from beginning or the second, third stage I was telling. And then he obliged for the Ipsilateral, which is a knee spanning one. This is a knee spanning Ipsilateral. As you can see, all the wounds have healed, barring the pus which was coming from the lateral side, and that was obviously debrided. Next one. So that was the post-op. Next one. This was about 9 months down the line. And next one. So this was the final union, which is 12 months down the line after removing the Ipsilateral. The whole lot, the wounds have completely healed, and the question of stiffness comes into the picture. Next one. This is the union, and this is the movement that he had. He's got about 90, 95 degrees, close to 100 degrees. He's got a lag of about, maybe 10 degrees, but he's getting straight. As you can see, he's lying down.
That's
So,
very
fractured after 10 years.
Excellent. Can you show us the final
Now he's
X-ray?
walking without any aid.
This is union.
Yeah, he's walking without aid at the moment.
No pain.
Which is 2019. It's 1 year since I've seen him. Hopefully, I see him in a better way rather than a nasty way. I'll probably ask him to come next month or so.
His range of movement is brilliant. I didn't expect him to get that range of movement.
Yeah, it was a big surprise to me also.
So
We
are
did say
moving
that the
on
range and
to-
movement we can't say anything, but somehow we got it.
Okay, great case, Ravindran. Well done. Now we are moving to the last case by Sunil. Sunil, you want to take this?
Yeah.
This is your ankle.
Okay. Amit,
Yeah, Sunil.
the fresh fracture.
X-ray.
Amit, what will you do?
Where is the articular surface? Yeah, it is there out.
It is floating.
Yeah, it is floating. No, a very good debridement, at least for 1 hour I would debride it properly.
Okay.
And this has got some soft tissue attachment probably. So this has got this articular piece, I would put it back after debriding it well. And add an external fixator and some minimal fixation intra-articular or just to hold this small piece. And fibula, I don't know if can you just go back to the X-ray? X-ray? Fibula would be plated, yeah. And this would, let's see, let us hope for that staged approach, if at all.
You will try to reconstruct or you will fuse it?
Yes, I would reconstruct because that intra-articular portion is a very large piece and it has got a attached soft tissue. Well, clean it properly. Did it have an attached soft tissue, Sunil?
Steve?
Next. Clinical picture. Yes, there is probably. Even if it was not there, I would have put it back after cleaning it properly and then fixed it minimally and waited with the external fixator and put a whack and antibiotic beads over there.
Gurinder, any different ideas?
So for me, I think I'm going to go, rather than do a CT scan, I'm going to take him to the operation theater, wash the wound, put the articular surface back. I know it's not a complete articular surface. There are pieces from the chipboard fragment and all are still lying in there. So I'm going to fix whatever I can with K-wires, put an X-fix, take him down for a CT scan after 1 or 2 days, then and put a whack at the same time with antibiotic beads. come back later and plan for a definitive surgery.
Any panel with different ideas, then raise the hand. Otherwise, we'll go on. Yes, Ashutosh.
I will not plate the fibula. I will just put a nail because I don't want to open it again on the lateral aspect.
Okay, well taken.
Because
The
it's a
same
transverse
management.
fracture.
I just asked one question. Looking at the X-ray, is that articular end that is on the medial side is completely free?
Yep.
Completely free.
This is the articular cartilage.
Yeah.
So, did you do that immediately, day one?
Yeah,
So,
this is day one, immediately day one. Immediately after the debridement, and we stabilize the, because we are not sure about this. It's a conveyor belt, injury of the conveyor belt. The patient has gone into some sort of some mud, some sand factory or something, and then she went into a accidentally in a conveyor belt. So just snapped it.
Will fibula, you left it alone?
Why fibula is nothing in the fibula?
I think it's the first stage that he's done.
At the moment, it is not there. So
why did you not put a rush rod in fibula, Sunil? You always believe in that.
always believe in that, but that time because lot of debridement, lot of things, we reconstructed that first on the medial side. We thought that we'll do it later.
Oh.
So
Go ahead.
we are not sure about whether the infection and everything on the lateral side, whether we wanted to plate. So let's see. But yeah, we did it later stage.
So was that ankle unstable? Why did you put that syndesmotic screw across fibula pro tibia?
Because the entire tibial condyle was outside. So you obviously the syndesmotic injury, ligaments, anterior, etiatal, epiphyseal, everything must have damaged. So I thought it is
Do you
going.
expect the ligaments to heal in this? Or probably it is the stability that articular surface is getting.
This is not the definitive line of treatment. This is a second stage.
Temporary.
You go ahead. Yeah. So this is after once we are convinced that the articular cartilage and the distal fragment is going to survive whatever the pieces, the loose pieces already crushed, they are gone. If you see there is a small step on the anterior part of the talus. Above that there is a cartilage, but still we can manage the small plate. You see, I have started using a small plate of the distal and radius, very small plate, not much the footprint concept. So don't damage anything. Just give enough stability for all these metaphyseal fractures of the tibia. Tibia will survive much better with the fancy plates rather than this distal and radius plate will give you enough stability for metaphyseal fracture. I have started using for this proximal posterior medial plating also. I use the same radius plate. But so this is after 9 months. Everything is healed up, and this is the range of motion for the patient. She's good. She's walking for so many years now, and she stays very nearby. Anything, anyone we want to call her, you can call for follow-up. Yeah.
Okay. Any
You want to
Yeah, one.
Yep.
Can we see the X-ray?
this X-ray or that last
Yeah,
one?
this X-ray also. The fragment is shifted posteriorly. It's in,
That's a posterior fragment.
would have been gone posteriorly instead of pulling it from anterior side. Could have buttressed from the posterior side if the wound allowed.
Because it was well whatever the remaining fragment of that articular cartilage, we have fixed it back. So whichever is remaining, we have fixed it that. We are absolutely sure. We are told patient that she may need an ankle fusion in future because the limb has survived. We are not sure whether it survived.
Your fibula plate is hiding that intra-articular lateral view of the tibia.
I didn't get you. What are you saying?
The fibula plate
Yeah.
is hiding that intra-articular tibia on the lateral side. So there I feel there is a step, but there is okay. For such a bad fracture, you got a very good
There is
result.
a step there. There is definitely because whatever the crushed, whatever the fragment was outside, we have fixed it back. But whatever is crushed, whatever was loose, Everything was removed in debridement.
This anterior distal tibial distal radial plate which you have put, it doesn't does it become too proud the patient for the patients?
That's what it is. The radial plate will not get proud. If you use any other fancy plates, it will hit on the metaphyseal area and it will get irritation. The tendons are moving. It's a very small, low profile plate. It will not.
Which are the fancy plates? The L plate, anterolateral L plates you talk about.
Small Alice plate. But nowadays I am using a locking plate. 2.7 mm locking plate.
Good, good. The end result is excellent.
Excellent.
Correct. So with this, I think we come to the end of this webinar we had. I thank all the panelists for your excellent contribution. There have been some questions. The chat box just opened up for me. I will take some questions out of these, if you guys allow me.
Yes, sure. On the contrary, question answers is important.
So, Dr. Shankar Gaur is asking how to manage floating injuries in children. So, Swardendra, do you want to answer this?
What is the question?
How do you manage floating injuries in children? Is there any different management than adults?
No, it is not different. Floating knee injuries, he is referring, I think it is still you have to manage with the X-fix. If it is if it is not compound or compound. If it is a compound, then you have to go for the X-fix and manage the soft tissue. If it is not compound, in a child, you can go with the immediately fix both the things. So that because in child, the union occurs very fast, you can fix it definitely.
Okay. Question to you, Dr. Sunil Kulkarni. What's the contraindication for puncturing the blisters? Dr. Kali is asking you.
Puncturing the blisters.
Contraindication for puncturing blisters.
There's a high chance of infection. If it's a hemorrhagic blisters, don't puncture it. It will heal. It will, once everything perfusion starts working, the nature will take care. Sometimes you can use a silver nitrite, but there's no need to put anything. Don't puncture it. If you puncture, it will, maybe there is a chance of infection. So don't puncture.
Yeah, exactly. So that you have to stress. Basically, you can add infection over there if you puncture.
A question for you, Amit. The question is from Dr. Arvind Kumar. What should be the common approach for fracture of lower half of thigh?
Lower half of thigh.
So I want to talk about lateral approach and swashbuckler both.
Approach or the instrumentation or what?
Approach.
Basically, in the lower end of the femur, he might be asking. Lower end of the femur is generally a funnel-shaped fracture. A funnel-shaped fracture, if you put an antegrade nail, for me, the antegrade nails, generally, if you are putting, you have to centralize the nails in the AP and lateral. Most of the times, whenever you put antegrade nails, you may centralize in one plane, but in the other plane, it is not centralized. So, and if you are doing an antegrade nail for all these fractures, either if the patient is sclerotic, aged patients, then you add polar screws over there for more stability. And you use a nail with an anteroposterior as well as the lateromedial lockings in the distal fragment. I am doing for all these lower end of the tibia femur fractures, not only the distal femur fractures, but also for the fractures in the lower third of the femur. I am generally tending towards the distal femur nail because it's a distal load-bearing implant, and a distal femur nail has got a thicker portion which is there in the distal part, as well as it takes good four planar and multiple lockings, and it goes up until the lesser trochanter. Okay. For me, this is the choice of implants.
Okay. So question for you, Sunil. What can be the implant selection in comminuted femoral subtrochanteric fracture with comminuted greater trochanter? So he is talking of unstable trochanter with an extension into subtrochanteric area.
So if you are able to reconstruct the lateral wall, the nail and the small buttress plate, what we are using a trochanteric plate with the hook plate or whatever the trochanteric plate, we can use it. But nail and the plate is the only combination, because the only DCAS or a contra buttress plate will not give any much stability because there is no purchase on the lateral wall. So lateral wall, medial wall, and if at all there you still feel, I can use a tension band also. Figure of it what we are doing.
So this is a question for you, Gurinder. and also for Amit, when to use distal femoral nail or distal femoral locking plate? Does it depend on geography of fracture or surgeon's choice? Dr. Pramod Raut is asking you.
So, in my opinion, it's a philosophy. I mean, I would, for an intra-articular fracture in my hand, the distal plate works very, very well. I don't feel confident putting a nail through it after I've got the joint fixed up, but I've got full respect for anybody who wishes to do it. I use it. I use a retrograde nail, but I use it for much more the metaphasal fractures. You know, the funnel-shaped area where the canal is so wide that you might be better actually getting more hold in the distal fragment with the retrograde nail. So in my books, the distal list plate is my go-to for all my intercondylar fractures, and my retrograde nail is to go to for my metaphasal fracture without an intra-articular extension.
For me, it is if after doing the CT scan, you know that there is good bone stock in the distal femur, and if it is an extension up to the C1. So I have done it for extended uses, extended indications till the C3. If you open, as it is for the C3 type of fractures, and with good bone stock in the distal femur, you are going to open the fracture. You are going to do you're going to reduce the intra-articular portions. After doing an intra-articular reduction, just nibble out a small entry point don't ream an entry point. You have to nibble out an entry point and pass the nail and put good lockings in the distal fragment. You easily bypass the metaphyseal comminution, and you need not think about the medial comminution at all. And put a long nail up to the lesser trochanter. You are done with it. If you plating is not a bad option, definitely it's a good option probably. But if you do a good plate like Gurinder or Sunil is talking about, a long plate distally and an added medial support either with an ender's nail or a medial plate would be better.
So this is a question for you, Sunil, on proximal tibia. Do you use collinear clamp to squeeze the intercondylar widening?
No, I use a big pelvic reduction clamp, which has got a big span so that we can compress. So once you put both the plates, so before putting the medial side, a lateral plate, because usually the lateral condyle is going inside, the lateral femoral condyle will go inside, as your case was showing. So the widening of the is done by compression, and then we put a latch screw so that it ends the compression. Then you put a locking screws of the plate.
Yes, that question was from Dr. Sumantu Virmani. Next question is from Dr. Alok Kumar Sinha, again to you, Sunil. Is why to continue X-fix after doing final fixation? The case which I talked about. Can you explain?
I didn't continue a final fixation. I never continued.
I did that because I was not too sure about lateromedial stability even after. So I continued X-fix for 2 to 3 weeks in that particular case. Question to you, Ashutosh. Role of primary Ipsilateral with proximal extension to femur and distract the knee joint with or without additional 1 or 2 CCS in proximal tibia.
I didn't get the question.
I also did not understand. This was from Dr. Chandrachud Bhattacharya. But anyway, primary Ipsilateral is a good idea, and we agree with you, Dr. Bhattacharya.
The only thing is, Sushruth, it doesn't have any role in a ligamentotaxis, if that is a question, for putting a joint spanning. You need to reduce the joint independently.
Yeah. So this is a question to Amit and Gurinder. What are the complications of suprapatellar nailing of tibia? Absolute indications for it? This is Dr. Rakesh Chandra.
Amit,
nowadays, for me, the trend is shifting from the normal nail to a suprapatellar nail. There are enough literature studies wherein they have shown that even in the distal part of the tibia, if you start from a suprapatellar entry, and if you get a good entry point, then you centralize the nail, you get a good reduction in the distal tibia also. For me, my threshold towards doing a tibia nailing is shifting from a normal tibia nail to a suprapatellar nail. For the proximal tibia, definitely I would go in for a suprapatellar nail. But the better nail which we have got available is from the Smith & Nephew, which I've used, and it is one of the best nails which is available. for the suprapatellar.
So in my opinion, I'm a recent convert to the suprapatellar nail, and I agree with Amit. Actually, it's a fairly easy thing. It's a mind block which I had for so many years of not shifting to that. We've used it for the ideal indication of the very proximal fracture and the very distal fracture. It actually works both ends of the fracture. It becomes almost an easy indication. One, the use of the II is very easy. The keeping the foot on it is very easy. You can do, a single person can actually do it. You need to be very sure that the patella glides very well. So you need to check the mobility of the patella very well. You might sometimes even need to do a slight medial parapatellar if you think the patella is getting slightly stuffed. But getting the starting point is the crux. It's easy. You should have the right nail for it. And it actually seems to be much easier to do compared to the other nail. The standard.
Once you do Gurinder, you fall in love with that nail actually.
Yeah, it takes a little time, but once you get over the block, and then you're on to it.
Yeah.
Okay. So this is question for Dr. Swarnendu. Swarnendu, what is the initial treatment protocol in a case of fracture of proximal tibia with impending compartment syndrome? Dr. Kulan Shekhar is asking you.
Impending compartment syndrome, proximal tibia, you just go for X-fix and you keep it and you observe. Don't go for immediately operation. Impending compartment syndrome, you don't have to jump for immediately for the compartment release, but you have to be very cautious. Tell your juniors that you please check all the 4 parameters in the foot so that you don't miss anything. Don't delay for the compartment release. But impending compartment syndrome doesn't mean that every time you have to go for the compartment release.
Question for you, Sunil. How to avoid wound healing complication in closed comminuted distal tibia fracture with distal tibia plating in above 60-year patients? Dr. M. Vinay Kumar is asking you.
No, I don't operate earlier as soon as any metaphyseal fracture. I will wait till the wrinkles sign. And in spite of that, even then, sometimes the plates are a little bit thicker. Nowadays, the low profile plates I am using. That's the reason we have no problem. The distal tibial medial plate sometimes say hello to you after a few days. Even then, you can wait, close it. Just small 1 or 2 screws are seen. I will keep it till the fracture unites and then you can remove it. Otherwise, it's a big problem. The flap will not be accepted on because your plate right on the middle malleolus sitting on that. So flap is also not going to help you unless you remove that plate and get something else. But I will wait till the fracture unites and then I can remove the plate and put on a task or something like that.
Okay.
So skin problem is there always when you use a thicker plate for the metaphyseal fractures.
Okay, this is from Dr. Vijay Singh to all the panelists. Do the panelists feel that all column fractured require a separate plate to fix the fracture? What is the sequence of plating if the fracture involves the column and require 3-4 column specific plates? Dr. Vijay Singh is asking.
The tibia, this is for the tibia. He is asking for tibia.
Probably it is proximal tibia.
So I think the main thing when you read your axial cuts, see where are the breaks, and the rule of thumb is that when you see your axial cut, where you can put your thumb best. Your thumb will dictate that where you should put the plate, and this should be anti-glide like you're buttressing the fragments. And always start from the medial side. If the 3 columns are fractured, you need 3 plates. If the 4 columns are fractured, you need 4. But you have to judge all the CT 2D pictures. Then only you can know where to put the plates, and always start from the medial side.
Amit, any difference of opinion?
I think a posterior plating we should do first, and posteromedial plating, if it is generally because the medial condyle is a better condyle with less combination. So you have to get a better condyle fixed and get a good articular congruity on the medial side first. Because lateral side, no matter whatever amount of elevation, bone grafting, if you do or not do, and the raft plates, you are not going to get an intra-articular congruity very well on the lateral side. You have to do a good posteromedial plating first and then go on to the anterolateral side. And first the posterior side plating and then the anterior plating, whatever you do.
Any difference in opinion, Sunil?
No.
Sequence of plate.
Posterior and posteromedial and then to lateral side.
Okay, so I will tell you the sequence to make it very clear. posteromedial, then posterolateral, then anterolateral, and then anteromedial if at all. Why? Because if you do not do posteromedial plating first and do anterolateral plating, which is the immediate reflex, you will never be able to reduce that posteromedial fragment. So always posteromedial first. Posterolateral is a difficult fragment. So if at all you want to fix that, Forosh approach or same approach, posterolateral fixation, then anterolateral, which is our conventionally used anterolateral plate, and then sometimes people use anteromedial plate, which can be used as an internal fixator or a definitive plating. So that's the sequence.
Because if you do anterior plating, Sushrut, first, which we used to do anterolateral platings and medial platings, only bipolar platings, you tend to put one of the screws in the posterior fragment and which distracts that posterior fragment. And then you cannot go posteriorly and get a reduction.
This is a question for you, Amit. How do you fix lateral meniscus to plate or soft tissue sleeve, full thickness bite in lateral meniscus or through its edges? Dr. Manish Kumar is asking you.
Lateral meniscus? In what fractures?
Submeniscal arthrotomy. So basically, Amit, I think you have understood
Yes, I think you should take
submeniscal.
Submeniscal approach.
Yes.
When we elevate the submeniscus, I didn't get it. If the lateral meniscus is stone or just after the submeniscal arthrotomy?
After approach.
Arthrotomy. He is asking for the arthrotomy.
Yeah, an arthrotomy is a submeniscal arthrotomy from below the meniscus at the submeniscal level.
How do you repair it as a question?
Yeah.
Repair it to the plate or the soft tissue?
Yes, he is asking how you reattach.
I repair it to the soft tissues, and if at all, if it is the bone is there, then with the suture anchor or to the soft tissues over there, not to the plate. I don't do it to the plate.
Sushrut, unmute.
Okay, question for Dr. Sunil Kulkarni from Dr. Ajay Goel. In first case by Dr. Sunil sir, comminuted proximal tibia fracture with intra-articular extension, can we apply a hybrid fixator with one or two olive wires proximally? Is his question.
Yeah, you can, but you cannot get a compression on the metaphyseal area. So, and the hybrid fixator will have 2 screws plus slack screw, and then you can take it. But we have stopped using for metaphyseal fractures any fixator. We can get good plates, so its stability is much better and patient compliance is much better. All hybrid or any fixator is little bit painful for the patient. So it is recommended, if you have a metaphyseal area, you can use a plate, which are much better and low profile plates.
Okay, so friends, this brings us to the end of today's webinar. Thank you very much, Science Integra, and thank you very much, Zuventus, to provide us with unrestricted educational grant for this purpose. Thank you, Sunil Kulkarni from Miraz, Amit Asgakar from Mumbai, Swarnendu Samanta, Kolkata, Gurinder Bedi from Delhi, Ashutosh Bhosle from Satara, and Dr. Ravindran from Coimbatore. Thank you very much, Subbu. We appreciate this highly. Zuventus, thank you very much. See you again. Stay safe, boys. Bye-bye.
Bye-bye.
Thank you.